More Akbare van Staden. Vandaag is een real soldaat. So early you have logged in.
Môre voorsitter, ja, ek is mos maar altyd vroeg, so hoe gaan dit met u?
Dit is goed met u en met jy?
Ook goed, dankie.
Dankie. Always early, eh? I see some members of department are logged in, the CFO. Yes, thank you very much. But I just wanted to comment on your early login. Yeah. I'm really taken up by this. Thank you very much. Good morning, honorable members of the Portfolio Committee of Health in the National Assembly. Good morning to the Minister, Deputy Minister and his team. Good morning to some of the other South Africans who are interested in our meeting, logged in here. We are in the Portfolio Committee meeting taking place virtually. We will assume that we are in this precinct of Parliament and therefore will do as it would be expected under such rules, that this meeting is taking place within the precinct of Parliament, and rules that apply in the House will also apply in this meeting. I would then want to say part of our work with the Portfolio Committee, some of these issues will come in between what we call program of action, and we hope we need to incorporate this letter. We are today going to listen to the department just giving us a progress report on what they've been doing since this House, this gathering actually supported the passing of the budget to allocate to health based on their annual plan. Now, there have been activities and certain things have happened. So this meeting today is coming in to do just that, to update and give us a progress on that process. So may I then start by checking with the secretary if she can indicate to us, one, the presence of the honorable members in this meeting. Ms. Machalamba.
Good morning and thank you, Chair. Present is Dr. Zomo, Ms. Treko, Ms. Tabangu, Ms. Sine, Ms. Clark, Dr. Leroux, Mr. Mutubati, Mr. Van Staden, Dr. Diklape, and Ms. Mhlongo. I haven't received any apologies yet, Chair. Thank you.
Okay, thank you very much. Welcome, honorable members. And we hope to keep you here up to a particular time slot so that you can then be able to move to be in the House at 2 o'clock. There is a budget speech by Minister of Finance, so we should probably all be there by 2 o'clock, and therefore we should really be mindful of where we are with the meeting today. Allow travel for those who may not be really be within the precinct of Parliament. We're having this meeting in the Dome, I'm told. Initially, it was thought it would be somewhere else, but it would be in the Dome. Right. Minister, we welcome you. And we want to, Ms. Machalamba, to flag the agenda, not actually indicating it may be the only item we have, but can we then flag the agenda so that I can get the confirmation of our members to accept or not to accept the agenda? Okay. Honorable members, we have done the confirmation of the attendance. No apologies mentioned. So we will be starting with just move it a bit. We'll be moving with the briefing by the Department of Health on this. We'll do it once and then get discussions thereon. If time still allows, we'll look into the item. Let me just put a proviso there. Because that is starting at 12, meaning that if the consideration of the adoption of the minutes will be affected by how we deal with this first part. Hopefully, we will still take that item. But then let me then get an indication from honorable members if we do accept that this is the item that we do have for today's meeting. Thank you very much. Can I get an indication of welcoming this? Thank you. You can take it away, Ms. Machalamba, now and get members to confirm whether we can go on with this meeting, with the agenda, and see Honorable Sene. Recognizing you, Honorable Sene.
Thank you, Chairperson. Good morning and good morning to everyone in the meeting. I want to propose the adoption of this agenda of today. Thank you.
Thanks, Honorable. Can you remind me again, you are Sine, not Sene, Sine?
Yes, it's Sine.
By the end of this term, I'll be able to pronounce it better. You know, me and Treko, we come down next to the sea, so sometimes we struggle to sound to pronounce it that way. Sne. Okay. Honorable Xhego.
Yes, good morning, Chair. Good morning, members and Minister and Deputy Minister. Comrade Chair, Honorable Chair, I rise up to second the Honorable that has moved for adoption of the agenda. Thank you.
Okay. You will introduce the delegation minister that you have, and then you will start with the presentation, or you will guide us who presents. Over to you, Minister. Thank you.
Thank you. Thank you very much, Chairperson, and thank you, honorable members, and my colleague, the Deputy Minister of Health, Dr. Joe Pasha, and the Director General of Health and his team, Dr. Buthelezi. Yes, Chairperson, it's myself here, and the Deputy Minister, Dr. Joe Pasha. The rest of the team, let me give the opportunity to the Director General, Dr. Buthelezi, to introduce the rest of his team, then I'll take over from there. Thank you very much.
Thank you very much, Honorable Minister, Honorable Chair, Deputy Minister, and Honorable members. Supporting the Minister this morning is myself, the Director General, the DDGs, Dr. Anban Pillay, responsible for state entities and regulations, Professor Nicholas Crisp, DDG National Health Insurance, Ms. Jeanette Hunter, who is the DDG for primary healthcare. We have the Chief Finance Officer, Mr. Pasoma Mohale, supported by Andre Fenter, who's the Chief Director for Financial Management. We also have Reverend Morewane, who's the Acting DDG for HIV, TB, STI. We have Ms. Q Gambo, who's the Chief Director for Human Resources, Ms. Tuli Zondi, who's responsible for M&E, Ms. Ribonensiye, who's the Acting Chief Director for Non-Communicable Diseases, then supported by the parliamentary support staff of the department. That's the team that's supporting the Minister. Over to you, Minister.
Thank you very much, DG. Honorable members, we are going to present to you a report for Q1, Q2, and Q3, which stretches up to December. This report does not include anything that happened for the past 6 weeks. It is only up to the end of December last year. The DG is going to take you through the report, honorable members. But before that, I just want to ask through you, Chairperson, the President has called an urgent special cabinet at 12 o'clock, which I will need to attend. So I will leave this meeting somewhere around 5 or 10 to 12, depending on how it goes, and go to attend the cabinet meeting, unfortunately. The second thing I wish to mention before the report starts, Chair, is that there have been sort of calls or even worry or panic because South Africans or people all over the world are wary of pandemics because of what COVID did to us. Every time they hear an outbreak of something, they start getting worried. There is this outbreak of hand, foot, and mouth disease in KwaZulu-Natal, crèches, schools, preschools, etc., places of young children, and it's worrying people. I just thought I need to take this opportunity to brief members of exactly what's going on there. Firstly, the issue that worries many people is that they know about the foot and mouth disease, which is a terrible disease in agriculture, which can collapse economies of countries once it starts affecting your livestock. Now, when they hear foot and mouth disease going to people, they might think it's a zoonotic disease. Zoonotic meaning diseases that move from animals to people. This is not a zoonotic. It's caused by a different virus. It is called hand, foot, and mouth disease. It affects mostly children, the age of 5 or under. It can affect anybody, but it's mostly in that age group. It's usually in summer and autumn, and you develop blisters in the mouth, in the palms of your hand, and the sole of your feet. That's why it's called hand, foot, and mouth. What confuses people is that the foot and mouth in animals, the animals also develop blisters in the mouth and on their feet. I don't think they are called feet. They develop what you call on their hoofs, rather. It's not feet. That's bad English. My apology. On their hoofs, they develop those blisters. Now, these are caused by completely 2 different viruses. Foot and mouth is caused by a virus just called FMVD, foot and mouth disease. And the hand, foot, and mouth in humans is caused by a virus called Coxsackie virus. It is a self-limiting disease, colleagues. In other words, it just goes away on its own within a week or 10 days. The problem here is pain. So when you treat only the symptoms, because as a virus, it doesn't really have any treatment, nor does it really need it. You just have to treat the symptoms so that the child becomes comfortable and not suffer pain. Now, at the last count in KZN, there were 117. The province is now moving from institution to institution, especially institutions of young people like preschools, crèches, and primary school. They are now just checking there what's happening. Presently, at the moment, the statistics is like this: 120 people in eThekwini Metro, 25 in King Cetshwayo, 20 in Ugu, and 3 in Mkhanyakude. These are the districts that are affected up to so far. Chairperson, the foot and mouth disease in animals, just to brief members, because we are now talking of One Health these days around the world, meaning the health problems in the Department of Health, the health problem in the animal health in agriculture, and the problems caused by climate change. We call them One Health. So we need to know all of them and be members of this committee. You need to know all 3 aspects of One Health. The foot and mouth disease in cattle caused by this foot and mouth disease virus, it affects only what we call cloven hoofed animals. That means animals whose hoof has got a space in the between, like a cow or cattle. Donkeys and horses don't have that space. And so they never get affected by this, but any cloven hoofed animal, whether it's a domestic animal or a wild animal, will suffer foot and mouth disease. And the biggest problem is economy, because once it affects your country, they cut you off from trade until it is gone. Now, the hand, foot, and mouth doesn't do such things. I just want you to relax. Work is being done about it. There is nothing to worry about, really. Thank you very much. DG, yes, can you take us through this report, please? Thank you.
Okay, DG, before you start, may I recognize a hand coming in from Honorable Michelle Clark? I was wondering whether maybe she doesn't want to wait. She wants to do it now. Honorable Clark, what would you like to know now?
Thank you, Chairperson. I just would like to, what the Minister has just said now, find it very interesting, because both my grandchildren have this disease at the moment, and many children in their school in Gauteng has been sent home for 10 days because of this disease. So it does seem that it has spread quite rapidly throughout the schools. And like he says, I mean, that's exactly what the symptoms are, and also a lot of blisters around the anal canal and on their legs. But, you know, very painful to eat and that, but they're not really sick from it. You know, it's just very uncomfortable and painful. So just to say to the minister, it seems like it's spread through the schools in Gauteng as well now. Thank you.
Thanks, Honorable Clark, and thanks for letting us know that your grandchildren are not that sick. Otherwise, we were not going to grant you any leave from this work that you are doing now. Thank you very much. Let's continue. Thanks, DG.
Thank you very much, Honorable Chair, and thanks to the Minister for the pre-assembly. We are briefing the Portfolio Committee on the first three quarters, of the year, and we will present according to the 6 programs, budget programs of the Department: Administration, NHI, communicable and non-communicable diseases, primary health care, hospital systems, health system governance, and human resources. So I'll start with performance information, and then I will allow the CFO to take us through the financial information. Starting with administration, on financial management, the target is an unqualified audit opinion, which we were in the last audit. We'll be waiting for the next audit, where we really aiming for a clean audit. Now we've had quite a number of years on unqualified audits. Then the second one is the payment of invoices, valid invoices within 30 days. It's only for the first quarter that we're unable to pay 6 out of the 995 invoices within 30 days, because there were issues with those invoices in terms of reconciliation of the quantities and the payments themselves. And the other one had issues of the bank details that did not reconcile with what is on the central supplier database. But for quarter 2 and quarter 3, we paid all valid invoices within 30 days of receiving them. In terms of the messages that we have promotion messages to try and address NCDs. We're targeted that at least at each quarter we will do about 50 messages, and we're able to surpass those messages that we were able to release through various platforms that we use, be it audio broadcast media, print media, and also social media platforms. And then it's as part of oversight, the minister, deputy minister, they actually do visit the facilities just to have first-hand experience in those areas. There were facilities that were visited, but we're short of 3 that in terms of our targets. And we have rescheduled this so that the ministers are able to visit that. Just to the presentation that was sent had a bit of a typo. On quarter 1, we had Steve Chwete Clinic as Free State, whereas it's supposed to be Northwest, which is now corrected on this slide. And then also community engagements, where the minister and deputy minister were able to be involved in a number of areas, and we've put in the areas where they were able to do outreach to the communities now, not really the facilities as such, and we exceeded the target by 12. Then in terms of employment equity, percentage of women at SMS level, this is director and above. On quarter 1, we're at 45%, quarter 2, 45.5%, quarter 3, 47.5%, which is still short of a target of 50%. Of course, this is directly affected by retirements, promotions, and people moving to greener pastures out of the department, but we strive to ensure that we have at least 50% of women at SMS position. So as to youth as well, we're looking at 30% of youth employment, and we're really not doing well. The youth is quite mobile. We do try and recruit youth even through the internship programs, but we're not doing well with this target. So we're quite very low in terms of the absorption of youth into the employment at the National Department of Health. Also with people with disabilities, the target is 2.5%. And we we only at 0.1% in this area also, which is not a very good performance. And we've put in the reasons why we are struggling. So we really need to actually try and have designated jobs that are for people with disabilities. So these are the corrective actions with the invoices. The delayed invoices were sorted out, and we do actually write, we do submit reports to Treasury on this. And whenever there are delayed invoices, a letter is prepared to the relevant DDG to actually investigate and take appropriate actions on why invoices were not processed on time. And of course, it must be valid invoices. Then, as mentioned, the visits to health facilities, they are rescheduled for later dates. And then in terms of the employment equity, we are revising the turnaround times for recruitment and selection, promotion acceleration, internal promotions for youth to be prioritized, and targeted recruitment and retention within the department for people with disabilities. We are implementing this. Then on national health insurance, the first one, we're looking at the total number of parcels delivered to pick-up points for the central chronic medication dispensing and distribution. In Q1, where we had a target of 2.3, we're unable to meet it, and I will explain why. And in Q2, we set the same target, and again, there is an underperformance.
Excuse me, Chairperson. DG, you are just saying 2.3, you are not saying 2.3 what? Remember, there are people out there waiting for you, please. So just be careful about how you, yes, please.
Yes, my apologies. It's 2.375 million parcels, and that we targeted for each of the quarters. And for the first quarter, we were only able to deliver 2.2 million, 2,246,820. For Q2, it's 2,275,296, and for Q3 is 2,384,000. And in that quarter, we're able to surpass the target. So, but if we combine the quarters, we were under by 218,758. And to explain, members, this is mainly because we are now moving into multi-month dispensing. If people were picking up medicine every month, some are now picking once in 3 months. We're also moving into 4 month and 6 month. So we are expecting these numbers to decline, because these are the number of parcels, because then the people will visit the pickup points lesser when they pick up for more months in terms of treatment, which is our strategy as we are moving forward. So it's not really an underperformance in terms of the numbers, but it's because of now the change in strategy. So when we actually do our targets in the next quarter, we'll take into consideration that people will be going less frequently into the pickup points. The next one is on the accreditation framework for health service providers. This framework is a framework that is going to be used so that we ensure that all the service providers, be it public or private, are actually accredited, so that they are able to contract with the NHI fund. The consultations, we obviously had to start with the Office of the Health Standard Compliance, and we also internally and also with the and externally. But all what that delayed us is that we needed to ensure that we start with the Office of the Health Standard Compliance, since the accreditation is reliant on the integrated with the certification process. That is why then we're not able to actually present this at the National Health Council. And now, once this is finalized, we'll then do internal and then external consultations, and then we're able to take it to the National Health Council. Then the next indicator is on the capitation model, which we'll use for primary healthcare, that the framework that needed to be developed. This will, of course, replace the current fee-for-service model that we use. And for Q2, we're really targeting that. We needed to have internal stakeholder consultations, and we're not able to commence with this one. And this was delayed mainly by the fact that we needed to start
recording in progress.
to do the NHI primary healthcare package that will be implemented as part of the CAPS framework. And that's what we're currently working, so that we're able to cost it, and then we'll be able then to start consultations internally. But however, we had started with the South African Medical Association on those dates, on the 17th of October and the 25th of November, because the people that will be mainly affected in terms of the PHC services, the GPs, groupings and representative bodies, hence the Medical Association, as we've already started with the consultation, so that when we finally costed it, we're able then to do the final consultations at that level. Then the other target here is on the electronic medical record. Here we've got two types of testing that we needed to do. One is the alpha testing, which is really a sort of an in vitro testing where we test it on the system that it works. Then if it works on the system, and then we then do what we call beta testing, which is now the field testing. We were able, even though we're not able to start on the first quarter because of the delay in the alpha testing, we were able then on the second quarter to be, we're able to start with the beta testing. And we are now in a number of provinces rolling it out. In the Free State, in Ditlhabeng, in the Northwest, in Mafikeng, in Northern Cape, in Hartswater, in Mpumalanga, in Middelburg, and in KZN, in Dundee, now rolling this one out with targeting at least starting with HIV and TB as the first modules. This is being rolled out in a number of provinces in terms of beta testing. And then the draft essential equipment list for healthcare service package that we needed to develop. Here we were able to appoint the technical committee on health technology, and this committee will at a later stage be converted into the Ministerial Committee, which will be in line with the Section 57 of the NHI Act in terms of the committees that will be able to be established. Then, as mentioned, in terms of the actions, beta testing was only done in the second quarter instead of first quarter, but we are rapidly rolling out. The internal consultation is planned for the last quarter on this accreditation framework. And we have appointed a number of consultants to support the costing work on the PHC package, so that we're able then to do proper consultation once it has been costed by this team of experts. Then in terms of program 3, communicable and non-communicable diseases, the first one is actually looking at polio elimination, where we're looking at the number of districts with non-polio acute flaccid paralysis, where the detection rate is greater or equal to 2 per 100,000 amongst children younger than 15 years of age. We targeted 11 districts for the first quarter, and we're able to do 23. And again, for the second quarter, we're looking for all quarters 11. We only underperformed in the second quarter. We only underperformed in the second quarter in terms of 4 districts, but we are aligning, and as we are supported mainly by the World Health Organization, to ensure that we remain polio-free as a country. And then in terms of human papillomavirus screening, this is screening that we use now for cervical cancer. Previously, we used to do what we call cytology-based screening, and now that has been proven that we can now use a different methodology, which is screening rather than doing a cytology. And we targeted that we will start this new approach in 4 districts in the first quarter. We are unable to do that, but we then rapidly moved it to in the second quarter. We rapidly implemented in about 13 districts. And then in the third quarter 10, so we're able to add 5 more districts if we combine the quarters. And our target is that all districts should actually be implementing this, as it is very important in terms of saving lives of women, as cervical cancer is actually the second killer, especially amongst African women. Then in terms of the malaria program, where they're actually doing their quarterly reviews, they were able to do all their quarterly reviews in the quarters, mainly in the malaria endemic districts, which are in Mpumalanga, KwaZulu-Natal, and Limpopo. Then in terms of quality of food, we actually do assessment of hospitals that are compliant with the norms and standards of what we call the food service policy in terms of the food that they serve to the patients. For the first quarter, we're targeting 20. We're only able to do 19 that were hospitals that were able to be compliant. Then quarter 2, we targeted 40. We surpassed by 2. Then quarter 3, we're 60. We surpassed by 5. So all in all, we were able to do more, 5 more hospitals in 3 quarters. And we really target that we do more of this to ensure that the quality of food served in hospitals is at the right standard. Then in terms of the national NCD campaigns, we wanted to do at least 1 per quarter. It's only in quarter 2 where we are not able to do any campaign. But in quarter 3, we then picked up and did 2 campaigns. So we did 1 extra campaign for the whole 3 quarters above the target that we had wanted to do. Then in terms of screening for both hypertension and diabetes, we surpassed the targets that were put because the annual targets were for hypertension was 10,161,000, but for the 3 quarters we're already at 30 million. And then for diabetes, we're at 16 million for the for the actual annual target, and we've already surpassed that because we're now sitting at 29 million. Then in terms of the state patients that are admitted into designated psychiatric hospitals, here, as we can see, these are the patients that are actually within the criminal justice system that are then certified that they should be, they have some mental issues, should be admitted to forensic psychiatric services. And with those 3 targets that we put in, but we're able to put in extra patients, and we only have 14 of these facilities in the whole of in the 8 provinces, with the exception of Mpumalanga. This we should be worried about because there's quite a number of people that are having mental issues, probably related to drug abuse, that then commit crime, and we then have to take them over as the state patients. Then in terms of HIV, here we're looking at the number of patients that should actually, we're targeting that they should be decanted away from the facilities to what we call differentiated models of care, so that they don't clog the facilities. And here at first quarter, we were targeting that at least we must have 2.8. But we did not reach the target, 2.8 million decanted patients. We were only at 1.705853 patients. For the second quarter, we wanted to increase this to 3 million. For the third quarter, we wanted to increase this to 3.2 million. All these targets were not able to reach, and we were under by 607,000, meaning that in terms of decanting patients, there is still a problem, especially in some provinces. In the Western Cape, we think it's mainly the reporting problem that we have there. In terms of the district information of the system that we use in terms of reporting. So we're trying to work with them to try and see how do we marry the systems so that they were able to pick up proper reporting from them. Our worry is that the provinces that have been doing well in terms of decanting, like the Free State and KwaZulu-Natal, they are showing a decline now in terms of the numbers that they are decanting. So we are really trying to see how we can deal with those 2 provinces and see what are the glitches in decanting the patients. In terms of the PHC facilities with use zones, for quarter 1, we wanted to have 2,125, quarter 2, 2,150, quarter 3, 2,175. And in quarter 1, we were able to surpass this. But as the members will be aware, some of the facilities, they get certified, but then they regress in terms of the standards that we set for that. So for the whole quarter, we can see that we actually minus 20 PHC facilities that were targeted. We're not able to get them through as having the proper youth zones. In terms of drug susceptible TB, the treatment success rate for the target for the 3 quarters is 83%. We are unable to reach this target for all the quarters. Really here it's actually ensuring that people that are on treatment, they complete the treatment and they are cured, because the treatment success rate is a combination of cure rate plus the completion rate. And here that means that there are some people that get lost. So we really need to get people not being lost to follow up, so that they can finish their treatment, so that we are able to reach the target that we have. Similarly, with the drug-resistant TB, the target for the 3 quarters was 73%, and for the 3 quarters, the highest we could reach was 64.2%, which is below the target. And the reason is the same for both drug-susceptible and the drug-resistant TB. Then people started on treatment. We had targeted that people who have been diagnosed as having TB should all be put on treatment, and we put in based on the modeling, the terms of the numbers. And for each quarter, we put in about 55,485. And for all the 3 quarters, we were unable to reach this number. The main problem here, honorable members, ideally, because we now use a gene expert to diagnose TB. The idea is that a person, you get a sputum, you do the gene expert, within 3 hours you get the result, and you initiate the person on treatment. But the problem is that the gene expert is only available in hospitals. So people that get tested outside of hospital settings, like in clinics, they can't get the results on the same day. We do the sputum, it gets transported to the hospital, they do it, then the results gets back to the clinic. So people can't get them on the same day and be initiated. So then in that way, we lose some people, and some even die before starting treatment. So it's a matter that we're addressing through the SMS system for letting the people know in terms of the results, that now the results are positive, please come back and be initiated on treatment. So as mentioned, in terms of what are the actions that we've put in place, we are following up and expediting reports on the outstanding provinces on the youth zones, just to ensure that we are in line with our targets. Then in terms of decentralized models of care or differentiated models of care, we are building capacity through training of healthcare workers on proper decanding of eligible patients. We are also facilitating ongoing training and improve accuracy and completeness on the data entry into the district health information system. And we are convening specific sessions and follow up with the Western Cape to address their data reporting issues on district health information systems. At the drug-susceptible TB, we are trying to find modalities of how do we ensure that we don't lose people who are on treatment. And we've even developed the adherence toolkit that will disseminate to provinces, just to ensure that we are able to deal with this matter. Then in terms of starting people on treatment, as mentioned, we are now putting in an SMS notification system to notify patients about their results, those who do not get them on the same day, that who are outside of the hospitals. Then in terms of primary health care, the first one is on clinics, ideal clinics, and we have targets that we put there. The methodology that we follow here is that firstly, we allow the facilities to do the self-assessment, and then we get in our teams to do the objective assessments. These teams, they are called PPTICRMs, and we've got the full name on an asterisk at the bottom, which means perfect permanent team for ideal clinic realization and maintenance. So in terms of the targets for first quarter, we wanted at least 3,023 PHC facilities to conduct the baseline self-assessment by facility managers. By quarter 2, then we wanted them to have these teams coming in and then to do the objective external assessment. This will then assist us that by this quarter, we should be able then to finally come up with a report in terms of what are the numbers that are actually certified as ideal clinics for the country. This will have in our annual report after the 4th quarter. Then similarly for district hospitals, we follow the same approach as the ideal clinic. This is a new program. Our target was that for the first quarter, we'll do 220 facilities, but we're only able to do 117 in terms of the self-assessment. Then in terms of the status determination for external teams, We wanted to the same hospitals, 220, to go through, but they were only able to do 73 hospitals because there was a delay in 147 hospitals in that area. So we've given them more time, but also we're doing more training, especially on this ideal district hospital is really a new program where we need to orientate the CEOs and the hospital management teams to be able to understand this program. At least the clinic one is an old one, and there's a better understanding at a PHC level. In terms of environmental health, this function, as we are aware, we are responsible for norms and standard, and it lies mainly with the district and metropolitan municipalities. So we always, our function is to assess them for compliance with the national norms and standards. We met all our targets in this area. We are not worried. But also we are developing an updated draft compliance tool, which we've been able to develop, and it's been piloted in 3 municipalities. So we're able to reach what we're targeted for this area. And then in terms of household community visits by the outreach teams, our target was that per annum we must do at least 14 million household visits. For 3 quarters, we've already surpassed this. We are at 14,218,049. And then the next one is on the number of provinces in terms of EMRS or ambulance services. So easily to put is that we wanted at least to assess in the first quarter 2 provinces, in the second quarter 3 provinces, in the third quarter 2 provinces. And we're really assessing them against the national regulations on emergency medical services. And we're able to assess all these provinces as targeted. Then in terms of what we're going to do, obviously for primary care facilities, we've granted them an extension, and we're adjusting the process to ensure that we are able to implement this program properly within the primary health care. Similarly, for hospitals, we are having an effort to assist facilities to conduct their self-assessments. And also the other issue here is that there's quite a lot of acting people in positions, and some they move between hospitals. So we need to do continuous training, but we're also providing oversight with the provinces and district coordinators in terms of the capturing of the district assessment, because it's an online tool where they have to get user accounts. So we are orienting them on this, and we're also doing site visits so that we support them on site to be able to do this work. Then in terms of program 5, which is hospital systems, here we're supposed to have a finalized hospital strategy documents. We're unable to do this. There's still quite a lot of consultation, and we should be able to get it in the next National Health Council to get it approved. So we're not able to have it finalized in the 3 quarters as we had targeted. Then in terms of primary healthcare facilities, in terms of infrastructure that are constructed or revitalized, we had those targets for quarter 1, 5, quarter 2, 7, quarter 3, 12. For quarter 1, we underperformed by 1 facility. For quarter 2, we overperformed by 2. And quarter 3, we underperformed by 8. In this area, you might find that what we find is that for us to be able to record that we've been able to deliver on the revitalization or construction, there's a system that we use which is called it's the Program Management Information Systems. It's called PMIS. Now, provinces, they have to load completion certificates into these systems, and sometimes they delay and they don't load it, and we can't then record. You find that they probably have finalized the work, but if it's not on the system, PMIS, then we can't record it because there's no completion for certificate. Similarly, in terms of the number of hospitals, those were the targets. For each of the quarters, we met in the first quarter. We underperformed by 6 in the second quarter, and we underperformed by 5 in the third quarter, with a total of -11 hospitals that we're supposed to construct or revitalize in the 3 quarters. Again, it's a similar issue. Either the construction is behind schedule because of some issues, or it's because of the loading of the completion certificate by the provinces on the PMIS. Then in terms of maintenance, repairs, or refurbishments, which are minor works, we are targeted. This includes all facilities, clinics, hospitals, nursing colleges, and EMS base stations. And in Q1, we overperformed by 1. In Q2, overperformed by 2. But Q3, we seriously underperformed by almost 60, if I'm not, by almost 50, if I'm not mistaken. So it's minus 38 facilities all in all. Some projects again were behind schedules, but then there was a similar issue of the delay in the loading of the completion certificates. And then in terms of quality of care and safety of the patients, it's a proportion of public hospitals implementing National Health Quality Improvement Program. For Q1, we're targeting will do 40%, increase to 70% by Q2, increase to 80% by Q3. We're not able to meet the target in the first quarter, but we then met targets in the second quarter and then also on the third quarter. So that means that with 2 hospitals less, in some of the areas, there was really a delay in capturing and self-assessment on the ideal facility system by the public hospitals. Then in terms of the actions, we believe that we should be able to present the draft hospital strategy to the next NHC in March. And then we are assisting provinces to commence self-assessments in terms of a National Quality Improvement Program. In terms of the infrastructure, we are working with the provinces. We've got teams that are going out to assist them to ensure that they load completion certificates at the end of the quarter, but we're also conducting regular oversight visits to provinces to verify the reported completed facilities. Then in Program 6, here, I think on the first one, we're looking at the number of audit action plans, looking at the entities' annual reports received and audit action plan developed. The only underperformance here, as the honorable members may be aware, was that only one entity, which is National Health Laboratory Services, was unable to submit their annual report in time. It was because of the cyber attack that they had, and some of the information that they needed for the annual report was the system that was on the system that was hacked, but they were able to then submit the report, albeit later than the regulated date. In terms of the audit action plans, we do have for the 3 entities, but for the 2 entities, which is the Office of Health Standard Compliance and Medical Research Council, because they had clean audits, there was no need to develop an audit action plan. So it's the others that had unqualified audits that we are working on their progress reports, and we received them. Then for the call for nominations for SAPRA board, which is South African Health Product Regulatory Authority. This board, because it was the transition of government, there was an agreement that we should, the minister should extend the board to 30 June 2025. And then we're then able to re-advertise, and it's been advertised already, and we are confident that when the current board expires on the 30th of June, there will be a new board at SAPRA. And then in terms of the South African Dental Technicians Council, we know the term of office was coming to an end. We have called for nominations, and we hope that this board will be appointed soon by the minister when the whole process of the advert has been finalized. And then on the National Health Laboratory Board, the request for nominations for candidates, on the first quarter, we submitted the request, and then there were members that were appointed in the second quarter, and the chairperson and the new chairperson and the vice chairperson were appointed for the new 3-year term of office, and there was a bit of a delay in nomination of candidates to be appointed to the relevant institutions. Remember, here the minister will normally ask the provinces and some of the departments at national to submit names. Then there's sometimes a delay, and we follow up with those departments. But in terms of those that are externally that we gathered, that process was actually done on time. Then on food safety, here the draft food labeling regulations here we're supposed to do the comments because they were actually gazetted for comments, and then do stakeholder consultation, and then by third quarter, finalize stakeholder consultation. We're delayed because we received quite a lot of comments on food labeling regulations, but we're currently busy with capturing those comments and analyzing them. Once that is completed, then we'll be then able to start with the stakeholder consultation. Then in terms of differentiated nursing education and training development plans, a framework for differentiated nursing, stakeholders were engaged on the first quarter, and the plans were developed in the second quarter. And again, they're still busy on the third quarter, but they are implementing at the same time as they are developing them. And we know that in most of the provinces now, they've already started with a postgraduate nursing program for specialist nursing, like advanced midwifery, theater nursing, ICU nursing, and others that are advanced. So it's an ongoing work that is aligned to the framework for differentiated nursing education and training. However, what then makes it complex is that it's not only the Department of Health function alone. We work with the quality assurance institutions like Council for Higher Education and SACA, South African Qualifications Authority. So we also depend on them because they also have to certify these programs once they are developed. Then, as mentioned, in terms of actions, though they had a delay because of cyber attack, but they were able to submit their annual report, that is the National Health Laboratory Services, and we're working on the food labeling regulations in terms of stakeholders and collecting the final input so that we can finalize the regulations. Then this table looks at the 43 indicators that we have. In the first quarter, we only achieved 40.6 of that. And then in second quarter, we went to 48.5. In the third quarter, we're sitting at 63.6% in terms of the targets. And we are working hard that we in the last quarter, when we do our final report, that will be better than 63.6 in terms of achieving the targets. Then thank you very much, Honorable Chair, Honorable Minister, Deputy Minister, and Honorable Members. May I ask the CFO to take over with the financial management part of the presentation. Mr. Mamukhale.
While the CFO is drinking the last glass of water to start, before I forget, Minister, we have just 30 minutes before we started, the CEO of NHLS did call, Professor Mlisane, wanting to know if we have already received the report, which I did confirm. So, honorable members, we must find time in the next few weeks to invite NHLS to then listen to their and go through their reports, which they finalized. The DG has actually indicated there was cyber attack on their system, but now they have completed that process. The report is ready. It's with us, and they just need a date, and I'm sure Ms. Machalamba will organize and actually invite them. I thought I should raise it now so that I don't forget. Over to you, CFO.
Thanks, DG. Morning to the Honorable Chair and Honorable Members, the Minister, Deputy Minister, and colleagues. DG will assist me with the presentation. So the first slide, we presenting the expenditure per program. So we are using the structure as the DG has been using in terms of reporting. So we're having the 6 programs in the department. So in terms of the budget for this department, we have 62.2 billion. And we also indicated the expenditure in terms of quarter 1, quarter 2, and quarter 3 as requested. But then we'll concentrate on the last quarter because it's the cumulative of the expenditure for all the quarters. And we also indicated the available budget, which is the budget that we spend until the end of the financial year. And we also do indicate the percentage spending as we have for each program. So we're also going to deal with the expenditure per each program. So when we go to the next slide, we have the expenditure in terms of the economic classification. So in here, Honorable Chair, we will start with the compensation of employees. This is going to affect the programs as I was also going to go in details per program. So in compensation of employees, the spending, we are sitting on 67%. The main reasons for the underspending is that by the beginning of the financial year, we had around 101 posts, which were prioritized for filling. But due to austerity measures and the process that we then follow with the National Treasury and DBSA, only 60 posts were approved. And of those 60 posts, we managed to fill 51 posts. And then the other 9, we could not fill because we could not identify the suitable candidates, and hence we have re-advertised for those posts. But also since April this year to date, we had the officials that they have also left the department, which is about 47 officials. So all that expenditure, it has affected the department, all the processes, they have affected the department in terms of filling the post, and hence then I'm explaining the percentage of 67%, and it's going to be the same as we're going to proceed in terms of each program. And then we also have goods and services, which has a budget of 1.6 billion, where our expenditure is 890 million, and with the percentage of 53%, and also the transfers, the 58.4 billion. So on the 58.4 billion, Honorable Chair, I'm also going to go in details in terms of each conditional grant, because that is the money that the national department do transfer to the provinces. And under capital, the 1.4, it's mainly our infrastructure indirect grant, where we also implementing the infrastructure in terms of the provinces. On the next slide, we will start with the program 1, where we indicate we're having different sub-programs within the program 1, which is administration. Our total budget was sitting on 761 million, and our spending was 447 million, and hence the total percentage spending is 58.7%. We also indicate in terms of each sub-program. Then in the next slide, we also indicate the economic classification in terms of this program, where in compensation, we are at par in terms of 75%. Maybe also, Chair, just to also indicate, because we present in the 3rd quarter, so the straight line spending, it should be around 75%, but however, because some of the items, they don't go in terms of the straight line, and then you'll see the expenditure being below or above 75%. In terms of goods and services, we're sitting on 52%, and we have less of the transfers in this program and also capital. In the next slide, we actually indicated the reasons where we had delays in terms of the IT equipments and also the IT security solution through CETA. So there has been delays, but we're doing follow-ups to make sure that we can finalize that. And also the payment of our departmental offices from December, which will also process until the end of this financial year. And then what we also have in the department is the centralized services within program 1 in terms of paying the fleet services, the air tickets, mobile communications, and other services, so that we ensure that we can pay invoices within 30 days as the DG has presented. And then after, we then reallocate this expenditure to other programs. And then in terms of the next slide is program 2. So program 2 is the National Health Insurance. We have in the budget of 1.3 billion with the actual expenditure of 783 million, and the total spending of 58%. And also here we're indicating in terms of the sub-programs, which is the program management, affordable medicine, and the biggest, which is the health financing and the national health insurance. So when we're looking at this expenditure in terms of economic classifications, also when we go to the reasons in the next slide, we do indicate the reasons for the underspending, in filling some of the posts for the program. And under goods and services, there was a bid for communication strategy amounting to 67 million, which it has been awarded. So 43 of that committed amount, it has been utilized, and the remainder will be used before the end of the financial year. It's the same with the Council of Scientific and Industrial Research, NHI Information Systems, where we have contracted 84 million that has been committed, and 36% of that has been spent, and the remainder it also be spent. So in terms of the stock visibility systems, the master health product list and the medicines, so we're still waiting for the invoices from the service providers from November. So those will be obtained and will process. And also there will be funds that will move between goods and services to capital, just to ensure that we are able to purchase some of the printers for the provincial health departments, as we also support the provinces in this program. When the next is the program 3. So program 3, communicable and non-communicable disease. We having different sub-programs, but in here just to highlight HIV and AIDS and STI, where we having the budget of 25 billion. But the total 25.1 billion on that sub-program, that's where we're finding the HIV and AIDS activities in the provinces in terms of conditional grants, which the details will follow. But in terms of this program, the spending is sitting on 74.2%, which is more in line. But in the conditional grants will indicate the spending in terms of the provinces. Then in terms of economic classification, on program 3, goods and services, we're sitting on 53.7%, and the transfers is the conditional grant that we have transferred. And in terms of the reasons in the next line, there is a procurement of the testing device and kits for provinces, which is still in progress, and also the issue of procurement of marketing on health promotions on TV, radios, and wrapping of municipal buses, which has commenced already. And an order for SABC side-by-side project was issued late to the service provider due to delays in finalizing the SLA, but that has been finalized, and the spending will proceed. And then in terms of program 4, which is our primary health care, we also having the 4 programs in there. The biggest being the district health services, where we're funding the community health care workers. The details will follow as we go to the economic classification, but the total, when we go to the conditional grants, but the total percentage spending is 73.2%, which is more in line with the straight line on the economic classification for this program. We also indicate the 52% in terms of compensation, 51% in terms of goods and services and transfers, which is the money that we transfer to the provinces. The next slide, we show the reasons here. The main ones under the goods and services was the bid specification for procurement of the electronic systems for issuing the women remains permits that are in process of being finalized, to make sure that we could then have an electronic system of issuing the permits for the women remains. And also the slow spending due to the program opting for the virtual meetings, which then it has also reduced some of the traveling costs. And then in terms of program 5, which is hospital services, the health facility infrastructure, that is the money that we also take to the provinces in this program, but it also has the 1.4 that we have in the national department, and also hospital services is the NTSG that we also transfer to the provinces, and the spending is actually at norm of 75%. Then the next slide, we're just showing on the economic classification for program 5. On the next slide. Then in here, it will be the same reasons in main in terms of the compensation. So here we also having the invoice for admin expenditure incurred by the implementing agent, which are assisting us in implementing the infrastructure projects, which in the national department we have in the 3, which is the IDT, DBSA, and the KUHA. And in terms of capital, as we are still awaiting for the invoices from the service providers through the implementing agent, so that we can then process those invoices. Then program 6, is our health system governance. That's where we have in the entities of the department, and hence in one of the sub-programs, we have the public entities management of 1.8 billion. So that's the money that we transfer. And we also have in the women resource for health, 5.5 billion rand, where we support in the provinces in terms of statutory HR and the training grant, which will then show the details. Then the next slide in terms of economic classifications, I think we will see in terms of the different percentages here, and in terms of goods and services, they're already on 82.6%. And the next slide, in terms of some of the reasons that the higher recorded expenditure than the ideal of 75%, as I've indicated, is due to the once-off national event, which was held for the traditional healers in preparation for the registration process of the council, and the other reasons it will be the same. In the next slide, we're going to go in the conditional grant. As we go in the conditional grant, Honorable Chair, just to also indicate, we having different structures in the national department where we support the provinces as they spend this allocated expenditure within the office of the CFO. We do have the provincial support team, which is being supported by the conditional grant managers. They do visit the provinces and monitor in terms of the financial and non-financial indicators, in terms of the business plans that they will have been submitted. And we also do have the CFOs forum, where we have all the CFOs in the provincial departments. We discuss the issues of the sector and also the finances, including the conditional grants, and also the support in terms of the audit processes, where currently the team has been visiting the Eastern Cape, Free State, and Northern Cape, which are only the 3 provinces which have been qualified, and we believe that there should be an improvement as we proceed. And then we do have the Tech NHC chaired by the DG with all HODs, and the National Health Council chaired by the Minister with all the MECs from the provinces and all other stakeholders to monitor all the expenditure and other targets that we have in terms of financial and non-financial. Just to go in terms of these conditional grants, just looking at the totals, then I think the next slide will go to the provinces. So in terms of the NTSG, we show the spending of 74.2%. We also, in the slides for conditional grants, Honorable Chair, you'll see towards the end on the right, we show the comparative expenditure in terms of the previous financial year. And then you'll see that we were also sitting on 74.7%. And there's no much challenges, but in terms of each province will indicate. The next one is the district health program grant, where we're having 2 components, which is HIV and AIDS and the district health component. In terms of the HIV and AIDS component, the spending is sitting on 68.3%. Just to indicate, Honorable Chair, it would be important, as I'm also on this slide, to indicate that the issue of the cyber attack in the NHLS, it has affected the spending on this conditional grant, because that has affected the billing on the NHLS, and there were delays in terms of receiving the invoices, in terms of paying for all the tests which have been done by the NHLS. Then we also have the district health component, where we're having our CHWs, our health facility revitalization sitting on 68.7%. And then we also have the statutory HR and the training grant within the program 6, as I've indicated, with the 5.5, with the 2 sub-programs, which is statutory HR and training grant, and lastly with the National Health Insurance grant, which I will also indicate in details when we go to the grant. So the next slide is just a graph where we indicate for easy monitoring, for easy analyzing the spending in terms of these conditional grants, where they were supposed to be on 75%. So we also compared with the previous financial year. You'll see some of the provinces mainly in terms of district health component. Last year we were spending higher than we were currently spending, and in terms of statutory HR, compared to last year and this year, we're still spending over 75%. Then the next slide, we also indicating the same expenditure in terms of the conditional grants per province. The next slide. So in terms of each province here, Honorable Chair, we have combined all the conditional grants that we gave to the provinces. And then here we show the spending in terms of the provinces which are still sitting on 64.5%, like Mpumalanga and KZN sitting on 65.3%. Will indicate the reasons when we also go in terms of each conditional grants, but mainly in Mpumalanga it will be the HIV and AIDS, and together with KZN, it will be part of the HIV and AIDS conditional grant. And the next slide, we also have shown the same in terms of each province where the spending, it has went a bit higher than 75%, like our Northwest, where it's sitting on 78.6%. And we also have the comparison in terms of the previous financial years. The next slide, we're going to start with the NTSG. So in our NTSG, just to also indicate I'll only indicate, Honorable Chair, with your permission, some of the outliers that we might have in terms of each slide. So in the NTSG, we have in the Northern Cape that, if we're looking on the spending, is sitting on 63.8%. And some of the reasons is the delay in the processing of invoices on the key accounts, and also on the tertiary services. The main challenge there is the attracting and the retention of the specialists in the province, and hence it's also affecting their spending. We also have in the Free State that sitting on 67.6%, but roughly the others are sitting on 70% and above, which then we believe the spending will improve, as the minister has indicated that these figures, they are at the 31st of December. The next slide that we have is on the district health component, on the next slide. So on this next slide, we have in the two sub-component. The next slide.
Apologies, CFO, and Chair, I'm now unable to move the slides. I don't know what has happened. May I unshare, and my sincere apologies.
I think that is fine, but Honorable Chair, because I was not made the host, I might not be in a position to share the slides, so I'll wait for DG. The next component that we were doing is the district.
May I request the Secretariat to help me? My computer has just got stuck in terms of sharing. It's not moving anymore. It was moving nicely. Johannes, are you able to help me?
TG, I'll try if I can be given the co-hosting rights.
Okay, try. I hope this has nothing to do with that the CFO is wearing glasses today.
Just laughing at that, Chairperson.
First time I see him with glasses. I don't know whether it's age or something. Yeah.
You got them from me, Chair. I borrowed them.
Chair, I tried to share this presentation. Can I just confirm if members,
yes,
members can see the slides?
Yes. Now it's showing a district health program grant.
Okay, thanks, Honorable Chair. I think the specs is so that I can see the figures correctly, Honorable Chair. But on the district health program grant, as I was explaining, that's where we're having our two components in terms of this grant. So the first component is the comprehensive HIV and AIDS component. So in this HIV and AIDS, we have in some of the provinces, mainly Mpumalanga, sitting on 56.3%. But then we had to check, as we're doing the monitoring, to check what are the reasons. And some of those reasons is because they did not procure the ARVs as they started the financial years. So they had the buffer stock in terms of medicine, but then currently they've been processing the invoices that they received at the end of January. They were sitting on 76%. And also there is an indication that there's an invoice of above 70 million in the province that is awaiting to be processed in terms of the ARVs. So the spending will improve. Also in KZN, where we're sitting on 61%. When we also checked the expenditure in terms of the January, it has improved to be above 70%. And some of the main reasons is the HIV monitoring tests, the underspending there, and also it has an impact in terms of the cyber attack from NHLS in terms of the billing and invoicing in the province. But then we also do have other provinces like Free State sitting on 66.3%, while Northwest is sitting on 80.4%, which is above the norm of 75%. Then the next slide is the district health component. That's where we're funding the CHWs, the community health care workers, which they've been deployed in different provinces, different districts to visit the households. In terms of this grant, Honorable Chair, the spending is sitting, because we know is the payment of the stipend, and we know that the payment will be processed to all provinces, and we don't expect any underspending in terms of this component. And then the next conditional grant is the health facility revitalization grant, which is the infrastructure, the money that we send to the provinces to improve the facilities. Also here, we have in Limpopo on 48.5%. And some of the reasons is that in terms of planning in the province, they have planned not to spend 75% by third quarter, so their spending, it will improve as they go to the fourth quarter. But then also the other reasons in terms of Limpopo and other province, which is Northern Cape and KZN, there were delays in terms of receiving the invoices from the service provider, and also some they were affected by December because some of the service providers within the building industry, they close around the 15th of December. And hence the invoices, they've been coming through from January to date, which the provinces, they're busy processing those invoices. And then the next grant, which is the statutory HR and training grant. So in terms of the statutory HR, the only outlier here is Northern Cape, which is also, when you go to the training grant, you will see that the spending is low, while on the statutory HR is high. But the main reason is just the reallocation in the province, which they are currently busy addressing, and also the Free State sitting on 58.2%, which we don't expect any underspending as the provinces, they are finalizing the issue of the ComServes and others. The training grant, also here, there's no challenge. The only one that I've indicated, Honorable Chair, will be Northern Cape, where they are showing the spending of 55.7%, while in the previous component, they were showing 155% spending, which it will be the misallocation that the province is currently finalizing to correct that. Then the last one is the National Health Insurance Grant. So I just want to explain, Honorable Chair and honorable members, so that they understand what is within this National Health Insurance Grant. So we have in two components, which we are funding under this grant. Firstly is the HP contracting, where the provinces, they appoint the GPs and they do visit our clinics or the PHC. So that is what we have. And secondly, we have in the mental health component, where we also supporting the provinces to appoint the mental health specialists that they will assist them in terms of the service delivery. So some of the underspending here, which we will see within Northwest, sitting on 47%. Some of the reasons, it will be the failure for the province to attract and retain some of these specialists to be able to assist them in terms of the delivery of services within different provinces. And that will be the last slide, Honorable Chair, but also just to indicate lastly, as we still waiting, as we still going. as we just finalizing, Honorable Chair, as we go into the financial year end, that as a department, we did not have the current fruitless and wasteful expenditure and irregular expenditure. Currently, we have been doing the follow-ups with the National Treasury in terms of the condonement of the irregular expenditure, while there have been processes within the department to reduce the fruitless and wasteful expenditure that has been recorded in previous financial years, which will be finalized as we finalize the financial year. So thanks, Honorable Chair.
Thank you very much, CFO. Now I know that your job comes with wearing glasses later in the job, very difficult. Honorable members, this is a presentation that has been detailed from the Minister, the DG, and the CFO. I will now recognize hands of honorable members who would like to engage with this presentation. And I have to scroll up. I see the one of Honorable Van Staden, number 1. I see Honorable Michelle Clark, number 2. I see Honorable Treko as number 3. And me, Honorable Shabangu, number 4. Okay. Is there any other member I'm leaving out? Honorable Mutubatse. Mutubatse, number 5. Scroll up a bit and see. Honorable Dr. Letlape, number 6. Number 7, Honorable Mare. Number 8, Honorable Sine. Okay. Okay. In that order, honorable members, just to confirm that none of you is left out. The first hand is that of Honorable Van Staden, followed by number 2, Honorable Clark. You will just follow one after the other. Number 3 will be Honorable Treko. 4 is Honorable Shabangu. And number 5, Honorable Mutubatse. Number 6 is Honorable Dr. Letlape. Number 7, Honorable Murray. And number last is Honorable Sine. Any member who has been left out and would like to engage?
Chair, my apologies, Chair. I had trouble with my microphone and my Zoom, but I would love to also ask some questions at the end if possible. Thank you.
Okay. Honorable Dr. Leroux, you will then be number 9. Thank you, honorable members. In that order, follow one after the other, starting with Honorable Van Staden. Thank you.
Thank you, Chair. I just have some 40 questions. I'm just joking with my. No, I just have 4 questions for the department and the minister. I just want to know what is the total number of vacancies currently in the department in terms of our doctors, our nurses, and our non-clinical staff. My second question is, do we have any feedback regarding the province's feedback on the contingency plans regarding PEPFAR? My third question is, I see there's NHI advertisements at the airports, on radio, TV, and other media. I just want to know what is the total cost in that so far. And my last question is, in terms of procurement of medicine, and this is all medicine, not only ARVs, are there any outstanding invoices that have not yet been paid? And if so, what is the total outstanding amount and for what reason? Thank you, Chairperson.
Yeah, if I may just request members to note their numbers now, is Honorable Clark, and then 2 will be Treko, 4 will be Shabangu, 5 Mutubatse, 6 Dr. Letlape, 7 Murray, 8 Sine, and number 9 Dr. Leroux, one after the other. Thank you very much.
Thank you, Chair. I've been covered in some retrospect by Member Van Staden, so I'm not going to repeat those questions. Then the following questions I would like to ask is, how often does the Minister or Deputy Minister do unannounced visits to health facilities? Because it's all well and good to have the red carpet rolled out and dirty dishes hidden when the hospitals and clinics know the minister's coming, but it might be an entirely different experience from what the patients and staff actually experience on a daily basis. Then what prompted the change to a 3-month collection cycle for CCMDDs? What were the technical challenges experienced in the alpha testing for the EMR? And what is the cost of the delaying the beta testing in both the timeline and in terms of funding? What is costs of the consultants working on the capacitation model? And how many consultants are working on it? And what are the terms of their contracts? Then what are the reasons for the declining decanting rates for HIV patients in some provinces? And how is PEPFAR influencing this? Regarding the employment of more community health workers, what is the current vacancy rate in each province? And since there is no budget to fill other critical vacancies, as the Minister has said many times, is there a budget to fill these vacancies? And how often does the department check whether self-reported ideal clinic status correlates with the OHC inspected ideal clinics? Because I'm very, very concerned that there might be some manipulation there. And what is the percentage of the correlation between self-reported OHSC inspection? And how far behind schedule are the infrastructure improvement projects? And what is the cost of the delays? What are the reasons for the delays? And are there any penalties imposed on contractors that do not stick to the timeframes in terms of these delays? And, you know, I'm very interested to know whether contractors that are appointed, if there are certain specifications that are imposed, to see that they actually have the skill set to perform these contracts, because we so often see at hospitals where these projects are so badly delayed or substandard building has been imposed, and you know, there's very little that's been done. So I want to know if all these things have put into sort of a mitigation plan. And then just in clarity, in terms of your 30-day payment ratio for your invoices, are we sticking to that 30-day payment ratio, or how many invoices are not being paid, and what are the amounts in terms of that 30-day ratio invoices? Chairperson, I have at least another 20 questions, but I'm going to submit them in written form because I don't want to delay your meeting. But there's some very, very important issues that needs to be raised at this committee, like when will the CUPS program costing be available, and what are the timeframes thereof? And in terms of mental health facilities, where we only have 14 mental health facilities, do we have enough healthcare workers in order to perform the skill set that is needed in those facilities? And what rehabilitation programs do we offer? Because when I've done oversight.
Chairperson.
Yes.
Excuse me, my apologies, Chairperson. I'm getting confused because I don't know what to do. We're taking notes here. Honorable Clark said she has got 20 more questions, but she won't ask them today. She'll do so later in writing, but then she goes on. I don't know whether she's giving us an example of what she's going to write or whether she's actually asking. Can we just get clear about that, please?
No, Minister, this is my last question, and the rest I will submit in writing. Because I really don't, you know, my job is to do oversight at this committee. I don't want to be stifled.
Sorry,
I just wanted to know that if the mental health facilities have rehabilitation programs in place, because I have found when I've done oversight that there aren't any rehabilitation programs in place. Thank you.
Honorable Van Staden, your hand is up again, or you forgot to lower it?
No, I was calling a point of order. The Minister must realize we are allowed to ask questions because we are the portfolio committee over his department and we're doing the oversight. So that's why I'm raising on a point of order, Chair.
No. Chairperson, I was not stopping anybody from asking questions.
I did not ask the Minister to respond. Honorable Clark, are you also back again? Or you have to lower your hand now?
I'll lower my hand, I'm done, and then I'll send the rest in as writing. so that I'm not stifled in doing my job. Thank you.
Minister, you came in when I was about to check myself whether she was making an example of what she's going to ask, or she was, and you moved a bit ahead of me. I was going to ask her, are you starting now, or you are just giving an example of what you are going to write down? So she has clarified that part. Let's move on.
That was my issue, Chairperson, and I want to dispel the notion that I'm restricting members from asking questions. I wanted clarity, whether those are questions or they are still going to come, that's all. So, Honorable Van Staden, don't claim that I'm trying to restrict members.
Minister, you don't speak in this meeting unless you are recognized. Okay, let's agree. When I opened this meeting, I said it would be conducted in the manner. If you want to speak, Minister, you raise your hand. That's why I was able to recognize Honorable Van Staden that his hand was up again, but he has just made an input. Then I recognize him. If you want to speak, you raise your hand. If you are in the house, you still raise your hand also there. Honorable Pego.
Thank you, Chair. Thank you. Good morning, everyone in the meeting. Chairperson, I have few questions to ask. The reason that lessens the number of questions is that a report it has been presented to us, and in the format of reporting, there is that last column, which I appreciate, that talks about actions to be taken to address the challenge. So now that lessens the number of questions because I have read that column. Thank you very much, Chair, for giving me the opportunity. But also thanks to the Minister about the briefing on the foot and mouth disease, the outbreak that has just come out. But mine is to say thank you for the information. We also would like that they make the public aware of such an outbreak, because any outbreak is a threat to communities. What measures, precautionary measures that they must take, what are the basic treatment, how to avoid the spread, at least that can be sent out to the public out there so that they know. I also appreciate, Chair, the mention of a National Health Council by the CFO, which I think it's an important platform to address the challenges faced by the health sector. Why I say so is the experience that we got in Northwest of shortage of water in one of the health facilities, and also what was there in the media about another health institution in KwaZulu-Natal on the shortage of water. We understand that water provision is not their function as health, but I encourage that they need to have a backup system. But it's good that SALGA, who is an umbrella body for municipalities, is also part of the National Health Council. I think other problems can be channeled there and be addressed in that council. But it's good to have the two services on electricity, water, to have them 24 hours, 365 days. So the backup system is encouraged, Minister. Coming to what was reported as 9 posts out of those that you were able to fill, the 60, so you talked about 9. Just even if it's not answered now, but to carry the assignment that they be categorized so that we are able to identify skills shortage. If it's hard for you, it's difficult for you to recruit individuals. But if they are SMS post, also the head hunting system, which is also a system to short-circuit recruitment, is advisable. Coming to the issue of TB, there's something that was reported on the TB the area that was talking about TB. My advice is, Chairperson, what you are proposing is correct, to have that SMS system sent to individuals. But I would like to say it out, there is still denial and resistance regarding TB. As South Africans, we are not taking TB as an illness, because illness is something that you can treat. If one can take TB treatment for the stipulated period, TB is gone. But there is still resistance and denial in patients. I would advise that we continue, the department continues with the awareness campaigns around the TB patients. And also the issue of training those that are doing tracing, so that they don't ask careless answers to communities, because there's stigma, there is still stigma around TB and HIV. It's important that there are community health workers working, but when they are tracing, because patients are now resorting in giving wrong addresses. How are they going to trace if patients are giving wrong addresses? We are mindful of the fact that there are those living in squatter camps and they can't give sometimes correct physical addresses, but others give wrong addresses because they don't want to be traced. Those are defaulters. Those are the ones that are transmitting the diseases to others. But a training for community health workers so that patients' rights are protected. A continuous campaign around that is encouraged. Coming to the issue of reporting, the department is reporting on Q1, 2, and 3 reports. They have that column that they put at the end of the that format, which I appreciated already. But the presenters must be able to say, since we are reporting about the 3rd quarter, come the 4th quarter, the situation will change, because there's something that is happening in between, so that ours is just to compare what has been reported and what is yet to come. I just wanted to have a say on that, Chairperson. Thank you very much.
Next member.
It's me. Thank you, Chairperson, and greetings to yourself and the Minister, the Deputy Minister, and other members in the platform. I must say that I'm largely covered by my 4 speakers, but then the first clarity sequence question that I have, because it would be clarity sequence question and comments maybe, it's on the Program 1 administration, because I believe that the presentation, anyway, let me first start by appreciating the report by Dr. Buthelezi and then the CEO, Mr. Pashwa. The Program 1 on the report that was presented by Dr. Buthelezi on the administration. And this report, I believe it covers Q1 to Q3. On the audit outcome, Q1 and Q2 is not mentioned, though we appreciate that in Q3, the outcome is there and the action plan is there. But it's a clarity seeking question on the exclusion of Q1 and Q2 when it comes to audit outcome. And secondly, one must appreciate that on Q3, all the invoices were paid, though in Q1 and Q2, there were those that were not paid. It shows that there is an improvement. On the issue of staff distribution, yes, I was covered also because the department is having an action plan to make sure that the women, youth, and people with disabilities are actually targeted on when they do their recruitment. We'll appreciate that target recruitment because we are more concerned about that if there are vacancies, the department must do this target recruitment to actually cover that area of women, youth, and people with disabilities, because there are so many people with disabilities that are having high qualifications, and also women and youth. The unemployment is very high. But the action plan is appreciated that is included there, and we hope that with the next presentation we'll see an improvement. Under PSC that was also presented by Dr. Telezi, it's they visited, I can't remember the slide now, but the report speaks to the PSCs that were visited, but yeah, and the target that was achieved in building new PSCs and those that were visited. But no, let me say it's a building, yeah. One would suggest that when we have these PSCs or hospitals newly built, maybe that if a department can have monitoring and evaluation. I know that the province is there maybe to do that job. I don't know whether, because now when we report here, get this report as the committee from the Department of Health, and we do the oversight, and then newly built hospitals and I mean PSCs that are not up to the standard. Because yes, we can mention the number here, but then there's something lacking when it comes to monitoring of this building. Because I'm talking, sitting here, I've done an oversight. There's a PSC clinic that was opened in October. And already there was community tutoring there. We went there for oversight. Nothing is functional. The toilet, the water, it's built in a wrong space. Similar situation that we found in Northwest when we were on oversight. But this one is new, opened October last year. So it's a suggestion that maybe randomly, these are the things that needs to be monitored. When we say we've got so many new PSCs, then we know that it's something that offers standard and it's functional instead of wasting the resources. Then on the the visit also, because we can see there that the report is speaking to the visits that were done by the department. One maybe would suggest that the report can just summarize or include the findings, because it's just the ideal clinics or that were visited, or PSCs or hospitals visited by the department. And out of so many, we visited so many. But then what one would be interested into is the findings by the Department of Health, other than our findings as the committee doing the oversight. Then the last one, like I said, that I was widely covered, is on the IDL of hospitals. The Dr. Telezi mentioned that this program is new in the hospitals. It's well vested in the clinics because it has been there for years. And there is mentioning in this report that those hospitals that could not assess themselves, do their self-assessment, were given extension to up to July 2024. But we are here now, it's February, and Are they still on that extension? What was the outcome after the July 2024? Did they do the self-assessment or they were given a further extension? That is not clear, unless if it was a finger error to say July 2024 on the report, maybe it's July 2025. That is why I said it's a clarity-seeking question. Chair, let me pause there. Thank you so much for the opportunity and thank you so much for the reports that were presented.
Honorable Mutubatse, followed by Honorable Totale Klape. Honorable Mutubatse, followed by Honorable Totale Klape. Totale Klape, can you come in?
Thank you, Chair. I'm not usurping Ntate Mutubatse's space. The question that was raised, I just want to re-emphasize the one about people with disabilities, the target of 2.5% with an achievement of 0.1%. We need to see what the plan is going to be. Are we going to use an outside agency to make that work? Are we going to speak to people with disabilities and their groupings to make them aware of the opportunities that lie within the department? The low absorption of youth in the Department of Health, I'd like to know how that squares up with unemployed young professionals, like with young doctors that are not being employed and we're not doing well on absorption of young people. The NHI and the CCMDD, how do they work together? Is CCMDD not a way of improving how our public health care system performs? Is our public health care system now being named interchangeably with the term NHI? Where does one start? Where does the other end? Now, just in terms of drug shortages, yesterday when I was in Stenga, in Kwatuguza, I saw a CCMDD clinic which works quite well. But the challenge becomes that ever so often, patients find a slip in their packet that says, not all your medications are available. Please contact the hospital. How is that process being managed? Because it's at the expense of the patient. And I just have concerns about when you have a packet of medication and nobody's telling you how they relate to each other, whether there's an impact on patient care. And the difficulties for the patient now being instructed to go back to hospital because there's a medicine missing. And if there are challenges at the 1 month supply, how do we deal with drug shortages when we are now giving people 3 months supply? I'm just concerned about how that's going to be managed. And I applaud the system. It's a welcome system, works well and saves a lot of headache for the patients and overcrowding for the facilities. The accreditation framework for health service providers being done in conjunction with the OHSC. The OHSC is about facilities. The other might include professional services. Where are the professional accreditation and relevant statutory bodies in this equation? When do they fit in and how is that assessed? The capitation and caps. How do we deal with specialist services in terms of what is being proposed? And I'm heartened by the fact that there seems to be negotiation with some. What about the doctors that lie outside SAMA? Because SAMA is not a statutory body, and there are other doctors that are not members of SAMA. How do we reach those? The essential equipment list committee. What is the role of the OHSC? Is that now going to sit as a committee of the Department of Health? Or should this be part of the sub-functions of the Office of Health Standards and Compliance? Because I presume that there will be criteria that would include equipment that would be essential in a facility before it is accredited. Where does that responsibility lie? Who does what? And can we get just a little more explanation in terms of what does that mean? Where is that care occurring? And how is it funded? What is the impact of outside donors like PEPFAR and global funds on those services? Or are we fully funding the DMOC framework? The ideal healthcare clinic, and we're talking about CAPS, are there criteria that have been created about what a contracting healthcare professional ideal setup should be? What is the minimum requirement for your physical facility and your professional qualifications? On the report about facilities that are constructed or revitalized, would it be possible to separate them so that we have a separate report on facilities that are being constructed and a separate report on the ones that are being revitalized, and be shown how revitalization is managed, how refurbishment and repairs are managed? Are there maintenance departments inside the institutions that do this, or are all these services outsourced, or we asking for tenders on those issues? On the Dental Technicians Council, just a question about sustainability, because there have been challenges about its size, the number of practitioners, and the upkeep of the register, of the register. And there has been suggestions about establishment of an oral health could be in one structure. The oral hygienist, the dental therapist, the dentist, the dental technicians. How is that being handled? Because we need to address these issues instead of continuing with new boards of structures that struggle. Just where are we with that? Can you explain just a little bit about the differentiated nursing education and training? Always had nurses with different bars of, advanced midwifery, psychiatry, etc. And how does that square up with the sentiment of reopening of nursing colleges, which were attached to health science faculties, etc.? Can we have just a little bit of an explanation and light thrown on that aspect? Now, the NHI grant that is being unspent, which is meant for contracting with GPs, how does that square up with unemployed doctors and not absorbed? And last question, Chair. The President in his SONA address spoke about a digital identity, and in other parts of his address spoke about the patient identification system. How does that meet with what is on the IT and patient information side? Are there meeting of minds, or are we creating all these things where if these are consolidated, identification system should be systems in a scarcity of resources when we are embarking on austerity measures. Thank you, Chair. Other questions I will submit directly. Thank you, Chair.
Honorable Khata, mute your mic. Honorable Mutubase is going to call and indicate to me when he's ready. He's got a challenge where he is, so we are working on that.
I'm here, Chair, if you can see me.
All right, then you can move ahead. Thank you.
Okay, no, thanks very much. I had a bit of a challenge. No, and thanks. I think one needs to welcome the presentations, Minister, opening, and the colleagues. I want to start here. Some years back, I came across a book called The Capitalist Nigger. And in his introduction, the author speaks about sometimes when you take a patient and put that patient in theater, and you don't have to apply anesthesia. And I want to encourage that because we are dealing with lives of people, that we must have the same approach as purported by this particular author, because I think the protocol within a particular
Honorable Mutubase, maybe switch off your video. It may just improve your connectivity. Thanks.
Okay. Okay. Am I okay now? Hello?
Yes.
Am I
I'm struggling to hear you. Maybe, I don't know whether it's my side, your side. Other members of this platform, is it audible?
We are all struggling, Chair.
I'm also struggling to hear him.
Honorable Mutubase, we are not audible to more than 6 of us, so maybe you are not audible to all of us. Maybe let's move to Honorable Mare while we check how to sort out your questions either to me or some other platform. Honorable Mare, it's your opportunity. Thank you.
Thank you, Chairperson. Chairperson, I want to welcome the presentation. I want to greet all the portfolio members and the minister and everyone that's in the meeting. I'll just have a few questions that I would like to ask. I was covered by the other members in the portfolio. I want to go to the targets that is not achieved, Chairperson. The targets that is not achieved, and what is coming to mind is that you talk about compensation of employees that is not being budgeted for. I just want to know, on your databases, don't you know how many people are at retirement age? How many people are leaving? And then how many people are you going to take in? Because those ones are going to go on to retirement. And then the other concern that I'm having, Chairperson, is that like the previous speaker was saying, the mental patients that we are talking about, we don't have enough mental hospitals. This is the same problem that I'm discussing in the portfolio of DSD, is that children get hooked on drugs. They become mentally unstable, mentally sick because they walk in the streets talking to themselves, and then it becomes a problem of the state. And then the state must basically give these people pensions for the rest of their lives. But in the meantime, we don't have rehab centers. I can speak about the Charlotte Muteka rehab center in Port Tabello in the Free State that is standing empty, state of the art. The problem that I'm having is that most portfolios departments are not talking to one another. And the concern that I'm having is that with the mental patients is that because it becomes a problem of the state, we are not preventing. We are not trying to prevent certain issues. We are just trying to control these problems that we are having. And that is a huge concern for me. The same with the TB patients. It's not that the TB patients are not going for the medication. I had TB when I was in 2010. I was basically a volunteer at Naledi Hospice and Sunflower House in Bloemfontein at National Hospital. I contracted TB, and the TB medication is making you very sick, very, very sick. But what I found out is that if I eat yogurt just after drinking the medication, it doesn't upset my stomach that much. So for me, I would like to say the department ministers must maybe get into a partnership with a dairy company or whatever, just to make sure that every patient that is having TB medication must have at least a yogurt to go with that, so that it doesn't upset the person because it makes you sick and you can't get up for the whole day. That is one of the things that I want to say. And then the other thing that I want to talk about is that the majority of the hospitals, I've been to Northern Cape, and in Colesberg, there's no Colesberg Hospital. There's no ambulances. The ambulances are not working. The car of the hospital is not working. So what is happening? They must go to Phillipstown and all the small towns around them, the R and those ones, because if a patient must go to Kimberley for an operation or something that is big, they must go lend ambulance, and that is basically unacceptable because afterwards the nurses are taking their cars to take these people to a hospital. And then I want to know about the shortages of staff. What is the plan for the shortages of staff? Because at the very same hospital, there's only 2 people that is basically that take the people from the operation table to the wards. There isn't enough of them. There's only 2 that is working there. The one is off duty, the other one is working alone. So I also need to know in the very clinics there in Northern Cape, there's no medication. People have been told to take Panado. Every sickness is just Panado, Panado, Panado. So I need to know is when people are resigning or people are going on pension, they don't put that people back in the clinics, in the very same clinics where I'm coming from in the East Free State. The people are not being put back. The nurses must work by themselves because there's no funding for those people to be put back. And then I want to know, we are talking about the IT system. The IT system, why are some clinics still using a method of writing down the patient's details and everything, where the other clinics are using computers? Why isn't it that all the clinics are on the same IT system? Why is it that some are not having computers? Why is it that some don't even have a proper filing system? And then the other thing that I want to know is the maintenance of the infrastructure. Some of these hospitals and clinics is falling apart, and there is no ways that I can see that something is going to happen. We talk about the building of clinics and how long it takes and all those things. But what about the maintenance of the infrastructure? Is there a budget for all these things? And how is it going to happen? Because with the shortfall and then also writing in patients is becoming a problem. And that is what is concerning, and it is very alarming at these clinics and hospitals that people are really struggling. And when patients are being treated badly is because nurses are under stress because they have to do with the little that they are having, and their work is not easy, and then they become frustrated and then they take it out on patients. So I just need to find out, if we look at our chief programs and you look at the budget that was spent and then you look at the underspending, what are we going to do about that? Because there's people that is really, really struggling to get what is needed for them just to do the day-to-day jobs. Thank you, Chairperson.
Next will be Honorable Sinne.
Chair, I thought I'm back.
Try again, because I advise you to switch off your video. You did, but there was still no improvement again. Try again now.
Is there no all right? Now let's check. If there's no improvement, then I will put them in writing. No, thanks, Chair. I was saying in my last input that I would actually appreciate if we can have an agreement in respect of the reports when we come into these meetings, so that we can have ample time to deal with them. I'm just suggesting that perhaps maybe 3 days before or 5 days before. Let me stick to 5 days before, so that we're able to go through them. That's what I'm suggesting. Now, the second question, Chair, is that just direct to the minister. Why must the minister visit clinics in the provinces and all this? What impact does it have? Because there's no secret that the national department does not have authority over the provincial health departments. Wherein, if you identify something, you will then have to go back to the very same provincial department and ask them to give you a report. Whether they do it or they don't do it, there's nothing that the department can do. One thing that is actually very painful to me, that I raised with the department, was to ask about the human rights that are actually being disregarded in one clinic in Guguletu, where there's asbestos, here in Guguletu. And I ask, what is it that the department is actually doing about that particular issue? The matter is being referred to one provincial department in the Western Cape, which the department is still to answer. So what is the use of the minister going there, but he doesn't have authority? Taxpayers' money is being wasted, us going there with petrol, then we come out, but we don't have any authority over those departments. So that's but one of the questions that I want to ask. Secondly, I've realized that the department have been speaking about the targets that needs to be met, just generally. The targets that needs to be met, but they have not been met, and there is no reason as to why an action that is actually been taken to corrective measures that have been taken. And if there are corrective measures that have been taken, one will appreciate if this committee can be taken to confidence to say that these are the actions that have been taken. But also, where there's overachievement, I've realized today that there's areas where there's overachievement. Are there any reasons, or did we sit down and want to establish why are we overachieving here? Because sometimes you might think that a runner is actually performing very good, but only to find that that particular runner is under the influence of some drugs. So you need to as well establish, but why is this particular person performing abnormally? And if there are lessons that need to be learned there, we need to actually know about those lessons. Perhaps maybe we can cajole everyone to move towards those reasons. Now, with regard to young people being employed, what is it that is different that you are doing to get the youth into the system? Because, Chairperson, it is no secret that we're having a crisis with young people not coming into the system. What is the reason? Why can't we get them into the system? Because clearly, and this puts me back to the outstanding posts that have to be filled, that was asked earlier. Now, what is the mechanism that is being used to say, for example, we know in the department that there are so many people who are going to live on pension this particular year. Do we really necessarily have to wait for the people to leave rather than starting the process at the human resource level, starting the process, because those posts have been funded, there's money that is available. My view is that you don't necessarily have to wait for the process to complete, but you must start the process simultaneously so that by the time a person leaves, then the post is filled. I think That makes common sense for me, so that we must not come back and say, no, look, we still having to advertise, this is what we need to do. So that would be my, my recommendation. We are so many years after passing an act on employment equity. Clearly, we cannot be talking about us not meeting the targets on people with disabilities. I think that's a shame on ourselves. We need to move with the necessary speed on both areas, on people with disabilities, on women improvement, making sure that we meet the targets. Actually, they must actually surpass what we have in terms of women, in terms of youth, in terms of people with disabilities. I want to encourage that we need to move with the necessary speed, because it is totally unacceptable that so many years we don't actually meet those targets. And just to advise or to find out, are there organizations that we are working with that can help us within that particular category to get people into the flow? And if that is the case, I think we must do that. Must encourage that the department should work with people with organizations with people with disabilities and also with young people, because I don't think we'll struggle if we take that particular route. Now, with regard to the TB test, we have the same day test at the hospital level. Come on. Why can't we have the same test at the primary care level, at the clinic level? Because that's where we need it most rather than in hospitals, unless otherwise I'm mixing the things, because that's where the primary care starts. So can I suggest that perhaps maybe we need to implement this particular system at that level rather than we catch it very late. Perhaps here we'll have more impact when it is we can do the test immediately, because the SMS, I hear the SMS, but in my view, we need to consider even taking this system at the clinic level. Now, on self-assessment,
Just
what?
mindful, Honorable Mutubase, that there are other members who still have questions to ask, and we still have to terminate the discussion at some point and move to Parliament. Other members are not sitting where you are in Parliament. So you are now on question number 11.
Unfortunately, Chair, I was not advised on how many questions I should ask. I should have been advised, but I was not advised, unfortunately.
I don't need to, just common
That's
sense.
fine, but I'm just saying, Chair, I don't want to cause commotion, but you did not advise. I think the principles is that if we started, you could have advised. People have been asking many questions. We did not count. I'm asking questions. Now you want to advise me. I think that's, to me, I think that's a bit disturbing, and it's actually intimidating me, I must say.
You don't want me to advise you to be mindful that we have a sitting in Parliament at 2. Some of the members are not in the Parliament as yet. So be mindful of that slot. That's all I'm saying.
I'm saying you should have advised us when we started. That's what I'm saying. Let me continue. On the question of self-assessment, that has not actually been, I heard, what are the steps that are actually been taken against individuals who have not done the self-assessment? Because the extension was given up until July 2024, as it was presented in front of us. Are there any steps that are actually been taken to corrective measures that have been taken to deal with that particular aspect? And with regard to, no, that's fine. I think let me stop there. I must say at the end, Chairperson, that I'm really disturbed by your intervention, which is not principled. I must register that, Chairperson. Thanks.
You do have a problem with that. You then write to the House Chair. There was an honorable member who came long before you. She said she has got many questions, but mindful of time, she was not going to raise those questions because she is mindful. So I cannot all the time educate members that be mindful. There are other members who are coming after you. If you are not happy about my ruling,
No,
you know,
Chair, I'm saying to you,
you are not
I'm saying to you,
no,
Honorable
Honorable
I'm saying
Mutubase, We are not going to speak while I speak. Wait until I finish addressing you. If you have any complaint regarding what I've done on the ruling, you know what to do. You know the rules to follow. Okay, let's leave it at that.
I know what I'm going to do, but I'm just saying that you must be fair.
Then you must write it down to those that are higher than us to inform them. Honorable Sine.
Thank you, Chairperson. Let me not repeat what my colleagues have raised. I'm actually covered. Thank you, Chair.
Honorable Dr. Leroux.
Thank you, Chair, and thank you for the presentation by the Department of Health and the DG and the Chief Financial Officer. I thought I'd just use this opportunity just to, with the DG available, just to say we have a statement in this regard that we are grateful for the guidance that has been given to to clinics and hospitals around the PEPFAR funding and how we need to mitigate this, and we're particularly pleased about the urge that the Department of Health urging facilities to provide 3 to 6 months of treatment and 6 months for people who are stable. I think that's a great move forward, and it's going to mean that we can decongest clinics, and I think that is something that we certainly should continue with going forward. And also, we also see that the department has recommended that there is task shifting happening in clinics so that we can allow for roles that were taken up by PEPFAR funded staff to be taken up by enrolled nurses and community health workers. So thank you for that clear guidance from the department. I have 1 or 2 comments and a few questions. My first comment just is in terms of the targets, and looking at the targets that the department has set, and of course those are the ones that the department are being evaluated on. I think the thing that stands out for me as a clinician who worked in rural and government hospitals pretty much all my life up to 2 years ago is that these targets are focused on administrative tasks that the Department of Health has to perform, and very few of those targets are assessing the service and the outcomes on the ground, and are looking at clinical outcomes. I think that is something that I would certainly like to see change in the years going forward, because I think that perhaps the only pure clinical outcome that we've got there is the cure rate for TB, and that number is unfortunately very low. And so I think that I would love to see the department, as it looks at targets for the next year, that there are more clinical outcomes that are being looked at that measure the impact of care service on the ground, including maternal mortality, perinatal mortality rates in hospitals, and what we're aiming for in those areas, and also looking at viral load suppression rates, etc., and people on ARVs. So I just would like to make that comment and perhaps ask as one of my first questions whether the department would consider doing something like that, and how that would be able to be incorporated into the targets in the next few years going forward. Coming back to the TB thing, so in terms of the DG has mentioned that that we've diagnosed fewer people than we expected. We also only sitting as a 67% cure rate, which is, if for drug sensitive TB, I have mentioned this before, this is actually shockingly low, and I think we need to. This is an urgent, and I want to echo what my colleague, the Honourable Plago, said, is that this is something that we need to address. This is one of the major killers of people in South Africa, and these killers in South Africa, and we are coming horribly short there. And so I'd like to hear from the DG and perhaps the Minister as well what our plans are to improve these numbers. I also would just like to, in terms of the numbers of patients being contacted, when I started working in the early 2000s, we didn't have a gene expert, we had acid fast bacilli, but the situation was the same. The vast majority of clinics did not have lab facilities in the clinic, and they would have to send the acid fast bacilli to a hospital. So this is not so much about tests as about systems in place. And I welcome the idea of sending SMSs out to people for the results, but we have to have good systems in place to make sure that people come back for those results when they test for TB. And that's not that difficult, but we have to make sure that those systems are in place everywhere, and we follow up everyone who's been tested for TB, and if they have a positive result, that we have a system whereby we can find them, or we can bring them back. And I think the other thing just to say is, in terms of, I think the biggest issue that we have in terms of not finding those patients with TB and not diagnosing them is that we're not doing any active case finding. We're doing very little household contact tracing, and we're also doing very little campaigns like X-ray campaigns with people. And I think we need to be actively going out into the community looking for TB rather than waiting for patients to come to us. So that is the comment, and I love some comments and thoughts from the minister and the DG on that. Secondly, in terms of the report that we have, I just when we know that medical legal issues, and we've spoken about in the committee before, are a major concern and a major budgetary constraint for us for the Department of Health. And there was mention of the case management system that was being rolled out, but there isn't very much clarity in the report about where we are with that. So I'd just like to know, in terms of the medical legal case management system that was being piloted, how far is that being rolled out? Has it gone to other clinics as well? I mean, provinces, the areas where it was initially piloted, and what is the progress that has happened there? Thirdly, I'd like to just find out about electronic management system. We've again heard that there are pilots. Would the portfolio committee be able to see, or perhaps when we go on oversight, see some of those electronic medical systems in practice, so we can see how they work early on, and so that we can again get a sense of what is on that front. Fourthly, in terms of the report given and looking at the budget items, one of the areas where there was an overspend was due to the traditional leaders event. Could I just get a sense of how many traditional leaders were invited to that event and what the cost of that event was and where it was held? And then finally, I just wanted to ask about a slide on slide 7, when we went through all the different allocations of budgets and amounts of spending, the chief financial officer did look at specific areas where we were over or under. There was one line item that I thought stood out, which he didn't refer to, and it's the 157% of budgets used in the Northern Cape in the statutory human resources component. And I just wanted to understand what had happened there. Why has 150% of that budget been spent, and is there any regularity there? Thank you very much, Chair.
Okay, thank you, Dr. Leroux. Minister, there was a question from Honorable Teko that spoke on about municipalities and the water problems. I think we are going to continue to say, has that been an issue that was affecting Prince Msheni Memorial Hospital? Even though I live in around that province, but maybe your update will assist us to say, have they sorted out the problem? Was it a municipality not giving them water, or how was it an issue there? Linked to what Honorable Leroux has asked is the matter that also I wanted to check. The DG is saying you are doing fairly well in terms of screening for hypertension and diabetes, but not all those screenings are translated into, for those who are actually found to be either needing treatment are started on treatment. So how big is that gap, and how do you hope to improve on just that gap? The third one is there's been an issue, you put it well, that the human papillomavirus vaccine campaign started in 2014, and yes, last year you were almost at the 10 years of that period. Now, we don't hear you talking positively, strongly about that campaign, because to date, there's a 20-year-old university student who probably was caught up at the very first year of vaccination and is now relatively free in the next few years to contract cervical cancer, and many more of such young girls. There is an information that is coming through. Have you started it to say, with the advice that has come through, that you can now do with a single dose? You were contemplating that, and therefore, once that dose has been started, you'll then be able to enroll any other 9-year-old that might have been left out, whether in the private school or in the special school. So please give us that information. The last one is on the WHO advice regarding polio. Are we already a polio-free country? If not, or if what is this other practice of keep on looking into the districts? Or we are saying probably we are, but let's keep on checking. So just to actually assist me to say yes, because once upon a time we had smallpox, but we don't hear you reporting on smallpox because you completely eradicated that part. Where are we in terms of polio? We still have to look back and check. Your phone. Minister, can you mute a bit? You'll be starting shortly to then answer. So it's just that part of wanting to check where we are now with polio. You still visit districts to check on that. Is it because you want to make sure you completely eradicate it, or it has already been eliminated, but you just want to keep on visiting? That clarity will assist. Then you can start, Minister, with your team and responses. Thank you very much.
Yeah, thank you, honorable members. Chairperson, I would really like to start first, even though we don't usually do that, but because I'm already at the door of the cabinet, in the next 5 minutes, it may start. So I'll pick up a few questions and answer them. And then I'll leave the others to the Deputy Minister, and the DG and the team. Chairperson, let me start by emphasizing that we don't really mind people asking questions. They may ask as many questions as they want. The job to control that is of the chairperson, is not us. But I don't want members to get irritated when we ask for points of clarity, because when you ask questions, we take notes and we don't want to misunderstand you. So what happened at the beginning of this meeting was very unfair. I was not restricting anybody from asking questions. I just wanted clarity so that I come to answer the correct questions. Chairperson, the few questions I will answer, especially on TB, because I really am answering it also politically. TB is curable, yes, but it has killed more people than all the infections added together, not alone. It has killed more people than HIV/AIDS itself, than cholera, than Ebola, than even COVID-19, yellow fever. Think about any infection that ever occurred in this world. When you add those infections together, TB killed more people than all of them. But yet we are still having this problem. The reason being that it is a silent killer. The word we've used was that it's not a drama queen. It doesn't come dramatically. It comes very slowly. For instance, even with the unions, when we address them, when they get very angry about mining accidents and mine fall, which kill mine workers, we show them statistics that mine workers are dying more from TB than all the rock falls that ever happened in the country added together. But it still doesn't evoke the same emotion and work as what you call as other diseases. For this reason, in 1998, the World Health Organization established a special vehicle called Stop TB Partnership, which has got an international board. I had the pleasure of chairing that board at least for 2 terms, for 2 occasions. It is based in Geneva, and its job is to try and encourage people about this issue of TB. Then a member of parliament in London, in the UK, then encourage members of parliament to get involved. Then a structure called Parliamentary TB Association was formed. Here in South Africa, it was launched here in Cape Town, if I'm not mistaken, but somehow it died off. And I think Honorable Jomo is trying to resuscitate it, to try and encourage members of parliament to get involved in this silent killer, which many people don't really think or know about. So I just want to tell you that, so that Honorable Jomo can get you together and we revitalize the Parliamentary Association of TB, because it's very, very important. One of the jobs it did in Kenya, one of the members who attended an international meeting in Kenya was able to stop a budget of a minister after coming from that meeting and found that the Minister of Health in Kenya read the budget with no item on TB whatsoever. And this member was from the Parliamentary TB Association. He has heard all the horrible stories about TB. So it's very useful. Honorable Mutubatsi, yes, common sense will tell you that clinics is primary health care. That's why things need to be happening. I'm talking about gene expect to diagnose TB. The problem, Honorable Mutubatsi, is that gene expect all over the world is a newly established technology. It is not a point of care technology. It's a laboratory-based technology which needs laboratory technicians who are found in laboratory networks. When we say hospitals have got them, is because hospitals are attached to NHLS laboratory network. Some of the offices of this, some of the laboratories, a network of 265 laboratories are found inside hospitals, and that's where they use gene expect. Otherwise, you can't take it to a clinic. It's not a point of care technology. That means it's not a technology that can be used by somebody who's untrained. It needs laboratory technicians and medical technologists. I am not sure, Honorable Mutsuwat, you mentioned something about anesthesia and the book called Capitalist Nigger, written by Chika Onyani. If I'm not mistaken, Honorable Member, Chika Onyani said nothing about anesthesia. The person who mentioned anesthesia there is Professor Ali Mazrui, who didn't write the book, but was commenting. He was asked to comment about the book, and he said Chika dissected Africa without an anesthetic, meaning he analyzed Africa and its problem so painfully that he was not putting his punches back, and he used the term without an anesthetic. That was the late Professor Mazrui, a Kenyan academic. So I'm not sure what, because your reception was not very good, what the issue was about it. I'll be very much interested to know, because I'm also interested about the criticism that Chika Onyani put on Africa and African leaders about the way in which we run our affairs. The other question I want to answer from Honorable Letlape was about, I'm sure maybe, or maybe let me leave that one to Professor Crisp, about capacitation, capitation and CAPS and specialists, because they really don't go together. You ask a question about CCMD and NHI, whether we're using them interchangeably. No, we're not. Some of these programs we are putting in preparation for NHI because they are going to be useful. For instance, CCMD will make sure that there is no overcrowding in our hospital, that people don't just wake up and go to hospitals to collect medication. They can receive it somewhere. That is a central chronic medication and dispensing program. There was a question from Honorable Clark about why we are moving away from 3 MMD to 6 MMD, meaning multi-medicine dispensing. It is not CCMDD, but they are related. 3 MMD is where you go to collect your medicines, but you collect a 3 months, is what you call package. You collect medicines for 3 months rather than 1 month as you go to the hospital. 6 MMD is where you collect 6 months treatment, so that you visit our facilities only 2 times a year. It was accepted officially by the Deputy President of the country in his capacity as the chairperson of SANAC in Quebec during World TB Day, when people living on World AIDS Day, not TB Day. World TB Day is still coming. On World AIDS Day on the 1st of December, where people marched to demand 6 MMD because it is more effective. They found it more effective for the reason that some of the people are working, they are working very far. They may be having employers who don't usually want to give them day off to go to hospitals. And so instead of visiting hospitals 4 times a year under 3 MMD, they go 6 times a year under 6 MMD. We're still planning to put that one into operation. Honorable Zomo, about HPV. We are the first country on the continent to start the HPV vaccine in 2014. I'm not sure whether other countries since followed, and we are very proud of it. It's a program that is going on very well, Romo. Maybe that's why we don't talk much about it, because it's moving very smoothly. We go to schools twice a year to give them that vaccine. Now they say you can only give there's a possibility of giving one dose. We are actually working on that one, but we really proud ourselves on the HPV vaccine, because in future we'll have lesser women suffering cancer of the cervix of the uterus, which is the second biggest killer after breast cancer, the second biggest killer of women in our country. And so that we could have a vaccine for it, we are very happy about that. Chairperson, maybe let me leave the others to our colleagues. As soon as cabinet starts, I'll switch off and go into it. Thank you very much.
Okay, in any order, maybe Deputy Minister will come last, or you can arrange now, DG and your team.
Thank you very much, Honorable Chair, and thank you to the Minister. In the order, I will ask Professor Crisp to deal with all the questions that have to do with NHI, the electronic medical record. The Minister has already dealt with CCMDD. Yes, so after Professor Crisp, we're going to have Ms. Jeanette Hunter, followed by Mr. Morewane, followed by Dr. Mahlati on all HR-related matters, and then the CFO on finance-related matters, and then I will come in and then hand over to the Deputy Minister. Over to you, Professor Crisp, and just look at the time as well when you're responding. Thank you.
Yeah, thanks very much, DG, and good day to the Honourable Chair, Honourable Members, Deputy Minister, and colleagues. So that
There's nobody here. Hello,
Minister. Sorry.
I'm sorry, I forgot to mute. My apologies. My apologies, Chair.
So, Chair, if I can go to the very first question was asked from the Honourable Van Staden about the cost of the NHI adverts. In this cycle, we have spent 28,462,209 rand on various components of that advertising campaign. As far as the electronic medical record is concerned, perhaps just to outline, because there were many questions about it, when you develop a new computer program or a new application like in the office and on paper and in the system, and when you go, then you go and you test it in the field, and in order to test it in the field, that's a beta testing. The beta testing started in the Free State in Ditlabeng, and that's where the users of that system get an opportunity to interact with it for the first time. They made some suggestions and changes of how it should look and how it should work and what it should do, because those are clinic nurses and some doctors, including some private GPs in that area, who commented. Then it was rolled out further to a number of other provinces with selected sites to test again that what had been said in the Free State still applies to other provinces, and that's where the fine-tuning happened. So as you heard, we have already implemented in sites in 5 provinces, and the 6th one is due any day now. So that's the intention is that this is our individual personal record, and it links, to answer one of the other questions, it links to the health patient registration system, which issues us our unique ID number for the health system. That is linked to Home Affairs, to our ID numbers. And yes, we have a very close working relationship with the Department of Home Affairs. You don't want to use an ID number to access your medical records, because ID numbers are widely available everywhere. So anybody would be able to use your ID number to access your medical records, and we don't want that. You will get a private ID number that's issued, but it's linked to your ID number, but it's also linked to your fingerprints, your biometrics, so that we don't make mistakes and confuse one patient with another patient when issuing treatment. The Minister answered the questions about CCMDD, but perhaps just to make it a little bit simpler as well. After we have seen a practitioner for any healthcare and we need to collect medicines, if there's a script, we can go and collect it from the clinics, from the pharmacy in the clinic or the hospital clinic if we've been in outpatients. We can go to a private pharmacy and we can go to CCMDD. So CCMDD is just a highly efficient way for patients to collect their scripts. And whether those scripts are for antiretrovirals and TB, and now that we are also including other chronic medicines, it's just a way that patients are able to collect their medicines outside of the formal structures. Some of that still happens in facilities, but some of it happens in what we call outside pickup points. The question about the accreditation and the relationship with Office of Health Standards Compliance, I think we need to be clear. These are completely different processes. Compliance testing is exactly as the Honorable Letlapi said, where it's about the facility, the services, and the structure of what happens within that facility. That is not the same thing as accreditation. In order to be accredited by the NHI, providers, and let's talk about them as establishments, will need to show which benefits they are able to deliver, what staffing they have, that they are using the formulary that is prescribed by the fund, which is, I'll come to the question of the equipment list in a moment, and that they are connected to the digital system and are contracted by the fund. That is described in the National Health Insurance Act as the process of accreditation, and that's the framework that has been developed so far. We do consult not only with SAMA, but with a whole range of other GP groups. The GPs around the country are not organized into only one national body, but they do link with one another through a network. And so we know which are the GP groups in the Western Cape, the Eastern Cape, KZN, and so forth. And there have been consultations around various parts of these developments with those different groups, and that will continue. We find it very fruitful to do that. Question of the contracting units for primary healthcare and capitation. So the intention of capitation is that a practice, which is usually in the past, GPs practice very individually, but now that the ethical guidelines have been changed in the HPCSA, they're allowed to practice in a more multidisciplinary way. And the intention is to form multidisciplinary teams who are allocated an amount of money for all the members of the public who get their healthcare there, whether you go there proactively or not. And it's costing that we are busy with, and that is what has required us to consult very widely with practitioners in the primary healthcare space. It's an evolving process, and it will start small, and once we are confident that it is replicable and affordable across the country, that is when we will roll it out. But we don't have time to go into all the details now. Part of what happens when you pay for a capitation is you pay a benefit that includes a service like a consultation, but also the products that may emanate from that service. And those products are not only medicines, they may include catheters, they may include colostomy bags, syringes, all kinds of other things. So the essential equipment list is the next step outside of the essential medicines list, where we are able to say, these are the items of equipment, both small as consumables, but also some quite bigger, that are part of what will be included in the capitation fee or as part of the primary healthcare package, but paid separately. And that's the process which was reported by the DG. I think I've answered most of them. I'll just quickly check if there isn't another one. Yeah, I think I've answered the question from the also about the digital identity. The IT systems. So if one tries to think about, there are many, many different IT systems, different hospital groups in private sector, different provinces, and so forth, use different practice administrations and hospital systems. But in order for us to be able to coordinate all of these services, we need these systems to be able to talk to one another. You can think of it about speaking the same language. And to do that, we use a process called an interoperability framework, and it is very complicated and quite sophisticated. But at the basis of it is that everybody must use the same language and the same structure with the same coding to be able to report. And then what you do inside the facility is less of a concern. And that is the process that we are busy with at the moment. We get very good cooperation in both the public and the private sectors with all the interoperability discussions that we're busy with, but it will take time. I think that also answers one of the questions from the Honorable LaRue about electronic systems. Yeah, I hope I haven't missed anything, DG, but I think I've covered the majority of the questions, and particularly those the Minister asked me to respond to. Thank you.
Thank you very much, Prof. Jeanette?
Good afternoon, Honourable Chair, Honourable Members, the Deputy Minister, the DG, and my colleagues. So I'll answer all the questions pertaining to the primary healthcare program, starting with the questions asked by Honourable Ms. Clark. And the first one in primary healthcare was about community health worker vacancies. Community health workers are not employed, they are stipended stipended volunteers. And that means that we do not have posts on organograms for community health workers, and we therefore cannot report on a vacancy rate. However, an investment case that we did in 2018, that was completed in 2018, that we did in order to lobby the National Treasury for funding to employ community health workers, showed that if we concentrate on the needy households, we need, by today's numbers, about 55,000 community health workers. And we currently have 45,000 community health workers. And we've done a new business case that was completed in 2024, because this conversation continues with the National Treasury to be able to get funding to employ the community health workers. Then there was a question about how does the findings of the Office of Health Standards and Compliance correlate with the findings of the Ideal Clinic. To date, we have 100% correlation. And there's also a unit within the presidency that does checks, unannounced checks on Ideal Clinics, and even from that program, there is 100% correlation, which means there is no clinic that we as the National Department of Health certified as ideal that was ever found wanting by the Office of Health Standards and Compliance, as well as the monitoring unit in the presidency. What must be remembered is that annually, the Office of Health Standards Compliance inspects a subset of facilities, a very small subset, whereas we measure 100% of functional facilities in the country. So our numbers will always be bigger than what the Office of Health Standards Compliance reports. Then there was a question about whether our mental health facilities have rehabilitation programs. Yes, all our mental health facilities have rehabilitation programs. Our treatment program within our facilities is called Mental Health Care, Treatment and Rehabilitation. And our rehabilitation programs are driven by occupational health professionals and social workers. There may be facilities where the rehabilitation is less than optimal, because we do have a scarcity of professionals across the board. And it would be good if we could get names of facilities where the honourable member has found that there's no or lacking rehabilitation programs, so that we could look into those and then see how they could be assisted. That said, the unit at the National Department of Health, as poorly resourced as what they are, do inspections at different hospitals per annum, but of course, we cannot get to all hospitals within a year. I'm just moving on. There was a question from Honourable Ms. Shabangu about what we reported on Ideal Hospitals, that the rate, that was during the first quarter, the rate of self-assessments for Ideal Hospitals was very low. and they were then given until the 24th of July 2024 to do those self-assessments. So that was not a typo, but that was a reason given in the report done by the DG for the low self-assessments during the first quarter, because we're reporting on quarter 1, 2, and 3. Subsequently, and this is what we picked up in quarter 4 now, this is why it's not in the report done by the DG, 247 district hospitals out of 253 has done the self-assessment. That means we are sitting on 98% of the district hospitals that's done the self-assessment. The other 2%, which is 6 hospitals, are under construction. No, under construction is the wrong term, sorry. Is undergoing major refurbishment. And therefore, it served no purpose to do an assessment in that facility. DG, I think I've covered the questions that was marked. I think the issue of the asbestos hospital, the asbestos clinic in Cape Town is an issue of infrastructure. Thank you, DG.
Thank you. Mr. Morewane, I know the minister has covered most of TB. Do you have anything just to add? Thank you very much. Being mindful of time.
Yeah, no, good day, Honorable Chair. Good day, Honorable Deputy Minister, Honorable members and the DG and colleagues on the call. DG, indeed, the Minister covered a number of these questions, but I just want to respond to 1 or 2 that may require my emphasis. The one on the contingency plan for PEPFAR, that we have regular meetings with the provinces. We have what I call check-in, check-out meetings. And as I'm talking now, the meeting for this week is going on with the provinces, where provinces go on to report to us on, firstly, what they're doing to make sure that they avoid the collapse of services, but also giving us an update of any areas where there could be challenges. And so far, we haven't received reports of disruption of services. So I must assure members here that that work has been done. And the impact, of PEPFAR, as I said, nothing has really led to total collapse of the services, so therefore we're very happy. I think DG, as you said, that a lot of these questions were answered. The ones on PEPFAR were really just repeated. Maybe for the Honorable Chair, just to assure that in terms of our awareness with regard to threat of polio outbreak, we do have regular meetings with the cross-boundary teams. We are aware that in Zimbabwe currently they are struggling, and we have therefore become very alert of that area. But for now, South Africa hasn't been threatened, hasn't identified any polio cases that we have in the country. So, but we don't want to sit on our laurels and hope that this doesn't happen. DG and honorable members and chair, I really think these are the questions that I needed to respond to, which the minister may not have touched. But if there are other questions, really, I'm happy to repeat. Thank you very much.
Thank you, Dr. Mahlati, on all HR-related issues. Thank you.
Thank you and good afternoon, DG Chair, honorable members, Deputy Minister, and colleagues. I'll start with the first one that wanted numbers in terms of the vacancies of doctors and nurses. As of 31st January, for medical doctors in the public health sector, of the 25,000, about 25,500 positions, we've got 22,079 that were filled. And we had 3,433 that were not filled. So these are vacancies where there would have been funding made available. But of course, the issue of vacancies is a moving target because if we check now end of February, we'll find that there would have been movement because of the recruitment processes that would have been in place for the nurses specifically. Of the 157,000 positions we have in public service, 135,928 are filled. That means that we've got warm bodies, 135,928. And then that leaves a balance of 21,444. And for both doctors and nurses, we're actually identifying all categories, that were involved. For other categories, Honorable Chair, maybe what we could do would be to pull the personnel report and be able to submit it, because the health system is not only doctors and nurses, but we can do that, following this meeting. I think the next one was around the low employment of young people. And I think, as the honorable member raised, it's a serious challenge, right across the country. As far as, where the health services, mainly the young people would be entering the service between ages of 20 and 30, just as an average. However, there are employment processes that have taken place where provinces develop annual recruitment plans, and now, subject to budget availability, then they would be able to fill in those positions. On instances where there are retirements, honorable members will recall that towards the end of 2023, DPSA and National Treasury issued what was termed Circular 49, which was meant to curb the expenditure on COE. First, it lasted until 31st March. Then it was 31st March 2024. Then it was extended to 31st March 2025. I'm not sure whether, in the light of the austerity measures, that circular, where the content of that circular will not be extended. What the impact that it had was that for any position that gets vacated through whatever means of attrition, that position immediately gets frozen. Then you need to apply to DPSA to be able to unfreeze the position. So the view that, has been taken is that once there are those positions that, come up administratively, and we know that is going to be vacant in the next 6 months or so, we would then write to DPSA and say there's this position, and then we motivate the importance of that position so that it can be, it can be unfrozen before it actually becomes frozen. Of course, DPSA would take its, processes to try and address that. On the matter of general staff shortages, it's mainly the rural settings that always suffer around that, which is not necessarily because of posts, but also because of issues of accommodation, where schooling for children and so on and so on. DG, I'll just touch a little bit on the infrastructure maintenance. Part of the problem there is actually the shortage around artisans, your plumbers, your handy people, and all that. And what some provinces have done, they've basically clustered, where those, like, for instance, you'll find that you've got 2 or 3 plumbers, then they would, demarcate an area where that team would then be able to service, let's say, a district hospital and all the clinics that actually, refer to it, as a way of trying to address that problem. Around nursing education, the nursing profession had a review of the nursing qualifications and made sure that they would be aligned to what the nursing service demands would be. And the major focus was on top of that, ensuring that specialization in nursing is actually extended and decentralized. As a result, there are three ways in which, people can access. One would be through universities, through colleges, and through private colleges, and all have to undergo accreditation by the Council on Higher Education, because I think about 5-6 years ago, nursing was actually taken to higher education. The last one, which is around employment of people with disabilities. Part of the challenge that many departments have been having, especially around administrative support, is really competing for a small pool, if one were to say that, because it's prioritizing people with disabilities, but making sure that they get employed in positions that they would actually be qualified for. It's much easier for physical disabilities. Part of the challenge, Honorable Chair, comes to where people would declare or not declare around disability that has recently developed, and especially around mental health challenges, because disability is not just about, physical. So I hope that I've managed to cover the last one. Sorry, I almost forgot. Honorable Dr. Hlape raised the issue about oral health services. We fully agree with him on that, and that's a matter that is taken up within the Forum of Statutory Health Council to actually say, how do those that are related actually come under one governance body, rather than having each of the fields being governed differently? Thank you very much, DG and Honorable Chair.
Thanks, Dr. Mahlat. CFO, we are the last one.
Thanks, DG. I will go through the questions from finance, as Mahlati and the colleagues, they have answered others. So I'll start with the question from Honorable Dr. Leroux. I think with regards to traditional leaders, the information that was requested, we will provide, because the question they wants to know where was the meeting and how many were in attendance, and also the cost related to that event. So we'll ensure that the information becomes available. And then with the Northern Cape statutory grant overspending of 155%, I think I have, as I was presenting, also indicating, if you look on the training grant, the same province, which is Northern Cape, they have the underspending of 55%. So in essence, what has happened, there was a misallocation between the two grants in terms of linking the employees, but then we have been in discussions with the province, and they will correct that misallocations. Then the other questions, when we start from the beginning, from the Honorable Van Staden, there was a question relating to outstanding invoices relating to medicine. But I think my response, it won't be only one medicine, because as a sector, because of the technical budget cuts that we normally have within the sector, and in the past, we have seen the increasing accruals in the sector. So when it comes to March, normally the provincial departments, due to cash flow challenges, they start to have challenges in terms of processing the invoices, and hence then we see the increased accruals within the sector, which I think by the end of this financial year, we will be able to give the statistics in terms of that. And the other question, which was asked by, I think from Clark, Honorable Clark, the issue of 30 days payment. DG, when he was presenting under Program 1, he did indicate that there were 6 invoices which were not paid within 30 days, but then I'll give the statistics in terms of all invoices that have been paid in the department from April 2024 to December 2024, where we have paid invoices, which is total of 373,754 invoices which were paid in terms of this department, and only 6 out of that were not paid within 30 days. And as they have also requested the value, And the value was 634,912 rand and 3 cents. So that is the money that was requested. And also just to note that on average, the department, we're paying actually the service providers within 7 days, not 30 days. So it just happened that some of those invoices are paid over 30 days, as DG has indicated during his presentation, as the invoices, they might not have the correct information as per the order, where we have differences, and also when the banking details do not agree with what we have within the CSD. And then we'll be requesting the service providers to be in a position to correct and resubmit the invoices. And currently, as per the end of third quarter, we're sitting on 99.84% in terms of the number of invoices which were paid within 30 days. I think that it will also cover some of the other questions which were asked by Honorable Shabangu with regards to payment of invoices within 30 days. The other clarity question was relating to Program 1 audit outcomes in terms of why the other quarters, they do not indicate the performance. So just to indicate the audit outcomes, it happens once a year. So when the audit from the Auditor General, they come and audit until the end of July, that's when we get the audit outcome. So then that outcome, it will be presented on that quarter. So the other quarters, they won't have the outcomes, but that it will cover the whole financial year. And the other question, I think, is the last question that I will answer from Honorable Dr. Letlape. When there was a question about the NHI grant, in terms of how does it link to unemployment of doctors, because there is no link between the two. This NHI grant is at the national level, where we give the provinces to appoint the GPs and those that they take them to the PHC facilities, while the unemployment, it will be as the Dr. Mahlati has explained. So it's a general compensation of employees. It's not part, or it won't be linked to the NHI grant. Thanks, DG. I think I've covered all the questions.
Yes, thank you very much. Jeanette, you missed a question on hypertension. I'm worried about time. If you can quickly just respond to the chair, and then
Yes, DG.
Yes.
Thank you, DG. Just to respond to the chair, the latest data that we have is from a 2022 report in the British Medical Journal. And they estimate that 31% of South Africans have hypertension. And of those, only 51% are diagnosed. However, of those diagnosed, 93% becomes treated. Just to answer the chair's question on the gap. Thank you, DG.
Thank you very much. Before I hand over to the Deputy Minister, on my side, just to be very direct to end the question, South Africa, yes, was declared polio-free in 2019. Initially, it was in 2006. Then we lost it, but in 2019, WHO declared South Africa polio-free. So we are polio-free. I think on the issue of Prince Mshieni, we've followed up. We've received a report. It was a municipality supply. The hospital does have actually two big reservoirs, which are about more than 1,000 megaliters. And also 20 that are distributed throughout the hospital. But what had happened is that because the municipality cut the water to the area around Umlazi, they used that water until all the water in the reservoirs was finalized. And then they've pulled in the water tankers that are owned by the department from the other district to come and support. So there is no problem at the moment, and there is a contingency plan. Thank you very much. Let me hand over to my Deputy Minister, Mhlonishwa Phahla.
Thank you very much. Thanks, DG. Greetings to the honorable members, chairperson, and all the honorable members. I'll be brief. I think most of the questions have been answered. Maybe just to take forward, just to add on what DG has said, Chair, what you asked about the polio, that of course to sustain the polio-free status, we are required to have structures and systems for surveillance. We are assessed on a regular basis, at least annually, under the WHO. And if it's found that our surveillance systems
are not up to scratch, that polio-free status will be taken away again. So that's where we are. Just to touch on two issues, one asked by Honorable Clark, but also related to a comment made by Honorable Mutubadze. Honorable Clark, indeed, unannounced visits are very useful. It is quite a bit tricky in terms of unannounced visits because at the same time, you don't want, you have to balance that also with the fact that you do need to, within the spirit of the Constitution of concurrent responsibility, as health is a concurrent function, you do need to also, do that within an understanding with your colleagues in the provinces and MECs that you are not necessarily playing some kind of police officer or some kind of a spy, but it's really in terms of just making sure that services are improved. Honorable Mutubadze then took it further to say what actually is the use, because as national political office bearers, you don't have direct authority in terms of the facilities. Again, just to emphasize that in terms of the Constitution and the law, these health services are a concurrent function. The day-to-day direct responsibility, of course, in terms of accounting authority is that of the provincial political leadership in terms of MECs, and the accounting officer being the head of department of the province who reports to the MEC. But in the spirit of cooperative governance and this as being a concurrent function, we do have a responsibility also at the national level, not only in terms of policy development and standards, but also overseeing to make sure that there is quality. And in the extreme, when all fail, if cooperation in terms of cooperative governance fail, the Constitution also does make room for the national sphere to can actually take over certain functions within what is within the Constitution, Section 101A or 1B, in the extreme, when everything has failed, national political authority and executive authority and also accounting authority. The function can be, and it doesn't have to be all functions in terms of the Constitution, certain functions within a portfolio can be taken over. But that's really when cooperation has failed. So it's not something which is useless to do.
Minister,
I think,
before you roll
yes.
up, before you do a final.
I think we can leave it there, Chair.
The hand of Honorable Dr. Letlape there. Now, I don't know whether...
No, that's fine. I think let's leave it, Chair.
No.
We can leave it there. Yeah, it's okay.
Are you raising a hand for something that was left out on your questions, Dr. Letlape?
Thank you, Chair. I was raising a hand. It was the issue about unannounced oversight visits, where we are being prevented from doing that. And we are being told that this is a provincial competence and CEOs are throwing us out. They are asking for directives from district managers, etc. Can we ensure, what I'm asking, Chair, is that can we ensure that at MINMEC, these things are clear? That we're not there to spy, we're not there to disturb, but we have a duty to oversight, but we have challenges with access and it imposing a danger to ourselves physically. Can
I request
Yes,
that you capture that nicely written down and forward it to our PLO, then they will be able to respond on that nicely. Okay. Wrap up.
I will do that.
Wrap up, Deputy Minister. Thank you.
Oh, okay. No, that's fine, Chair. Just the last matter, which also I know that I think the CFO did touch on that. Just two issues from Dr. Letlape. One on the essential equipment list, This is really to almost a mirror image of the essential medicines list. So he had asked as to whether this is not the function of the Office of Health Standard. On the other, on the contrary, honorable member, the department, national department, is responsible for setting standards, including what are the basic equipment, what are the basic pharmaceutical products which are required at what level of service. So at this stage, it is a function which is, a part of it has already been happening, but we want to strengthen it to make sure that there is a very clear standard equipment list at various levels of service. Also knowing that, it can be quite a tricky thing in terms of making sure that facilities are up to standard. And lastly, on the CFO touched on the issue of the NHI grant and unemployed doctors. Again, just to say, the NHI grant it's preparing for the capitation and making sure that at the primary healthcare level, personal services, we support provinces to make sure that personal services can be provided, not only in terms of those who are in employment, but also that they can also, with a view that in future, in fact, we're looking at the stage where even GP practices under the capitation system, rather than just GP supporting clinics, can actually be contracted. So that's a different model compared to the compensation of employees budget, which is what we need to improve in as far as employment of full-time doctors is concerned. I think let me leave it there, Chair. In the interest of time, I know we are all running late to go to the House. Thank you.
Yeah. Thank you very much, Deputy Minister. Honorable Dr. Leroux, whatever you do have, please write it down. Whether it is your question that has not been well looked after, or we have a new question.
Okay, no problem. Thank you, Chair.
Yeah. May I request, because we are now wrapping up and moving to another last item, that I have a challenge when I get into my car in terms of audibility on your side, that the last item be handled on my behalf by Honorable Clerk, or the issues of minutes, so that I could then be able to start moving wherever
Recording
I am.
in progress.
Can I just check, Chairperson, when you deal with minutes, do you require us?
No, we don't.
Okay, so we can be excused.
Yes, you can then be excused, Minister, with your team. But let me then formally thank you before I hand over to the Honorable Clerk. Thanks very much. Any outstanding questions, Honorable members, and those questions that you raised and were not well attended to, but I think they were all well attended to. Any additional ones, like Honorable Clark said, she has another group of questions, please write them on time. Our PLO will then take them and then get the department to process that to bring it back to us. Thank you very much. Honorable Clerk, please take over from here, my Honorable Chair, to assist me so that I can lead. Thanks.
Thank you very much, Chair. You are released because of what you have just raised as a network problem. Honorable members, we are on the last item of this agenda, which I think we are entertaining minutes. Can you, Vuyokazi, and your team assist in that regard of flighting the minutes? Am I audible, members?
Yes.
Okay. Can Vuyokazi and team assist us in flighting the minutes? Ms. Majalamba? Ms. Majalamba and team? Anything to say, Honorable
Hi,
Shabangu?
sorry, Ma'am Kako, I was sharing the minutes. I'll share
Okay.
them again.
Okay.
Can you see them now?
Do you see them, members? I have a problem with my gadget on my side.
Yes, we can see. She must roll them.
If they can see the minutes, all is well on my side, even if I can't see them, but members are seeing the minutes. Is there anything on page 1? Assist Vuyokazi. Anything
Page
on page
1.
1, members? Is there any hand up? Yes, I do see now. On the attendees, check on your names, spellings, attendees, apologies. Anything on that page, members? It seems none. Vuyokazi, the next page. Members, the next page is there. Have you anything to say? It seems none. The next page, Vuyokazi. Which page is it, Ms. Machalamba now? You are on page?
We are on page 2, going to page 3.
On page 3, anything, members? Nothing raised. Let's go to the next page, page 4. On resolutions. Anything to say, members? And the item 5 on those minutes was the adjournment. In overall, what is the meeting saying about the minutes? If there's anyone who has raised a hand, just indicate it to me, Vuyokazi.
Shabangu, Chair.
Honorable Shabangu, what's your take on the minutes?
Chair, thank you very much. I want to indicate that the minutes are a true reflection of what took place on that day. So I raise to adopt these minutes.
Thank you, Honorable Shabangu. Anyone seconding?
I second, Chair.
Honorable Sine is seconding the adoption of the minutes. On that note, I think we have entertained our agenda as it was agreed upon by the meeting. Let me then take this opportunity to thank the members who have connected to the meeting, thank the department for making a presentation that we have entertained in the meeting. Thank everyone who has connected to the meeting. I think it is that time that I must thank you all. The Miss Machalamba team, we also acknowledge the assistance that you always provide in our meetings. Thank you very much. Till we meet, honorable members, thank you very much. The meeting stands adjourned. Thank you.
Thank you.
Thank you very much.
Bye, everyone.
Thank you
See
very
you in the
much.
door.
Thank you. Bye.
Oh, thank you. Bye.
Thank you all. Goodbye.